Hi guys. Okay, I was just waiting to become host, but before I become a host or a ghost or whatever it is, let's just start the class because it's late. Okay. Thank you all for joining me. I hope everybody had a good weekend. I most certainly did. I hope you all enjoyed your weekend, but you're here again and we're back to the grind, guys. Well done. My former students are here. My regular attendees are here. So proud of all of you. And today we're going to be doing gynae. Yes, see, Arshi is so active. Arshi's like, oh my God, I can't wait for Monday. And everybody hates Monday, but Arshi is the best because, she's like a genius. Everyone's like impressed by the way Arshi speaks in this class. I'm telling you, Arshi, you are doing very well. And I'm very proud of you. Okay. You're making me proud because, you're my student and you're doing that well. Although I know it's actually you. You're amazing. That's why you're doing well. But then, it feels good to be your teacher. So I hope everyone gets to that level and everyone will because I believe in all of you. Okay. So today we're doing women's health, okay, which is gynae. So basically in Plab 2, gynae presents with about 30 cases and it's super intense. And you're just looking at those 30 cases and you're like, honey, this is a lot. Like, how do I complete this? And then comes your lifesaver, your angel, your guardian angel, me, who I have made the gynae into this compressed logic. Because when it comes to gynae, whether in Plab 1, Plab 2, there's a lot of topics in there. There's a lot of memorizing in there. There's a lot of like, gynae is a separate topic, OBS is a separate topic. So two things you have to memorize. You have to memorize OBS diseases, then you have to memorize gynae diseases, then you have to memorize even the vaginal infection stuff. That's why I dedicated a whole day to it. But I assure you, with this whole day, I will make sure, and it's like a guarantee that I'll give you, hopefully, inshallah, that you will be able to grasp gynae. And this is not going to be a major deal for you after today. Okay, because the way I've explained contraceptives, it's going to be like my best work yet. Okay. One is in peds. I have a vaccination rule, how to memorize all those vaccinations, their timetable or whatever you call it. And the other is this contraceptive is I feel like this is my best work, like because I took some time to work on it, and you guys are lucky enough to be able to experience it. So everybody, I hope you're all active. Everybody knows that it's Monday. It's difficult to be active on a Monday. I completely understand. But that's not a problem because we have Arshi, we have Aisha, we have all of you. Who else is active? Please write down in the chat or tell me because I don't proceed without
Me,
activing.
me.
Actually, I was waiting for Seher to speak. I was just like acting like, someone speak, hello. Okay, well done. So basically, Shaista, open up, open up.
Okay, I'm active too. Hello.
Well done, Shaista. Well done. Okay, well done. We can start now because I think majority people are active. That's what I want. Okay, everybody has to participate. Everybody has to be active listener. There's no such thing as just listening. No such thing as just listening while you have to be an active listener to gain something out of this. Okay. Maybe just listening in your subconscious mind, that's not going to benefit you as much as if you're actively actually listening to this. Okay. So we all know there's a basic history structure. We've all learned about it. Let's go through the basic history structure so that it's super duper memorized in your head. Okay, and then we'll talk about the gynae structure. Gynae structure is almost the same. Okay, that's why I'm making you mem. Okay, go ahead. Who's gonna open their mic and tell me the first part?
Intro.
Well done. So wrapper building is the intro part. Number two.
Yeah, then the history, the
Okay.
P1.
No. Give history of what? History of like his family.
Oh,
Sorry.
no, the presenting complaints.
Well done. Okay. So the complaint, what is his complaint? And then very good. The presenting his history of the complaint, which is OD
Maybe
or
para or 40 para. OD para or 40 para or the Socrates.
good. What if it's like a liquid,
The
like
there was this one, the four word, I think 4 to 5 word. Um, wait. Like some people use 40 para, the frequency thing in
yeah,
that, but there is
let's not
one
get
more.
that.
Track, I guess.
Yeah, very
That
good, very good. Even 40 para is fine, very good. So coming to the fourth part, what's next?
then the red flags.
Very good, nice. I was completely about to forget those. Very good. And then
Then after the red flags, we need to rule out the P. maftosa.
very good. Then 6.
then social history, उसी में आ जाएगी social history, and then the sexual history as well now, the gynecological.
During this part, go for the special questions, any special extra added questions that you need to ask that are
Okay,
not included in PMF TOSA. Simple as that. Then,
okay, and then ice.
very good. So
Ice.
proud of you. The idea part of ICE, this is my biggest hack. Do the idea part of ICE during the history taking part, because even if you ask the concern, you won't be able to address it because you're not allowed to give any information until we get to the management part. And by then you might forget the concern by the time you get to that part, right? So that's why my advice to
Yeah,
all of you, or my hack, is that try to ask idea during the
during the
question
history.
part. Yeah, very good, Sir. But the concerns should be in the management part. You can ask concerns then, because at that time you'll, otherwise if you ask him concerns right now, he's just going to be like, yeah, doctor, I have a concern that my daughter died or whatever it is. So you're going to be like, okay, I'll come back to your concern. And later you'll forget the concern. And then you're going to waste another time. Oh, what was your, could you revise your, so there's so many chances that you might mess up the active listening part. You might mess up addressing his concern. And then you'll have to re-ask. So your time will get screwed up. So this is I've very strategically made these structures so that not even a tiny bit of a microscopic mistake can happen. And you guys will be safe with the structure. Okay. So,
Okay, then this concern question should be like in the P1. Like we should ask then and there, and we should like answer it then and there.
yeah, in concern, the taking part of the structure, which is the history part where you do the complaint, you do
Yeah.
the PMF, where you do the special question, don't ask concern yet. Only ask one thing of the ICE, which is idea. Okay. But when you're going
Okay.
to the management part, then you ask concern. Okay. I've already added concern.
Okay.
I've given
Okay.
concerns a
Okay.
lot. So tell me, who's going to tell me the structure of management? Very good, Seher. Now, who's going to tell me the structure of management?
I want to tell. It's
Go
first
ahead.
thing we will tell the diagnosis. First, we will say him thank you for giving answering our questions. Then we will briefly say about the examination, and in examination, after that we will just say about the general examination and from head to toe, and we will tell one or two bed tests, whatever
Okay,
will be, whatever will suit with that. After that we will tell that from your history and examination, we found this diagnosis, one word diagnosis and one sentence of explanation of
very good.
diagnosis.
Brilliant, brilliant, brilliant. I thought she only said the diagnosis part, but honey, she remembers everything. That's amazing. She's been studying. You can tell that someone's been studying. Very good, Shaisa. So, diagnosis. Tell him the diagnosis. Okay. What's next?
After that, yeah, after that we will ask them that do you want me to tell you more about it, and when he will say yes, we will explain and the further management plan, whatever it will be according to the diagnosis.
Okay, Shaista, but that's not the structure that I taught. What happened after diagnosis? Don't you remember?
Then we need to like see that if it's an urgent referral or it's normal, the routine referral, and
Very
we are
good.
going to involve a senior, and we are also going to before that we are going to do some investigations, the routine
Exactly.
blood test.
Why are you involving senior? Senior, not in every single case you can involve your senior. That's
Mm,
the wrong approach. Yeah.
yeah, just in a general case, like if it's
Okay.
something an emergency, then we need to remember that we need to involve senior as well.
Ha,
Is
I
it
get
any
it.
emergency case? Ectopic
Honey,
pregnancy, I guess. Yeah.
yeah, okay, but don't, in my basic structure that I've taught, let's go for the basics. Don't involve senior right now.
Okay.
Okay? What did I say?
Okay.
Diagnosis. Then what did I teach after that? It was tests.
Yeah.
So now we're going to run
Investigations.
investigations. Then comes the treatment part. Okay, that's when you tell
Mm.
them urgent referral or whatever you want to admit or discharge. That comes in that part. Okay, so you can do the first you have to tell about the test. Only then you can come to the treatment part where you tell him, I'm sorry, you have to be admitted. Okay, then
Yeah.
once treatment is done, what happens next?
Concerns.
Safety
Very
net.
well done. Concerns. This is the part where you
Mm.
ask concern. Up to now, is
Okay.
there
Okay.
anything running in your mind that you'd like me to address? So that's how you work. You go for concern. Then he'll be like, yeah, doctor, actually, I don't want to be admitted. I have a dog at home. Oh, then you just address his concern, whatever it is. And then comes what happens next?
Safety.
Safety net.
Very good.
Then
Safety
leaflet.
net is fine. Safety net is very good. Okay. Just make sure you add the counseling. I'm going to show you guys my board one more time and memorize the structure. If even one mistake happens next time, I'm not going to let that go. I'm just kidding. Okay. So I'm going to appreciate you. I have that side, but then I also have a dark side. It's not always rainbows, is it? So here we go. This is the structure. No one's going to mess it up again. Okay. Rapport, then complaint, then explore the complaint, then do the red flags. Seher did this part very well. Special questions, and then came Shaista, very good. Examinations, the diagnosis explanation, then do the test, then treat, then ask his concerns. You can counsel him at this point and use safety net. After that, if you want to, you can do this. So this is very, very strategic. I don't know what to call it, like strategic or whatever, strategically planned timetable. So anything, you can never fail. Use this structure and you can never ever fail your exam. You can never miss anything if you use this. So I'm just getting you guys used to having this in your reflexes. That's why I always make you guys rememorize this during our class in the beginning. Okay, now let's go to the awesome obs and gynae. Damn, this is gonna be too good. Okay, guys, ready? So here we are. Okay, so obs and gynae, basically women's health, consists of two parts. Why? I know that's really painful. It's like obs, separate diseases, gynae, separate diseases. Worse with gynae is, gynae doesn't just have the pregnancy, like I want to get pregnant diseases, but gynae also has that a whole like domain where you have to learn how to not get pregnant. So you have all those contraceptives. So it gets really annoying. So yes, I understand that women's health is difficult. However, I went through the whole, like I took the bullet for you guys. I worked really hard on this topic. There's like 30 cases that are going to be really difficult for you to understand. But I made that difficulty part. I took that and I made this whole 3-hour like class for you so that you are able to do those cases in no time. Okay, guys? So let's start with the first part of women's health, which is OBS. Okay, whoever's gonna attend this class is extremely lucky. Wow, my board just disappeared for some reason. Damn, I don't know why it disappeared. Just a minute.
I think I clicked something and it disappeared.
Thank you, Sarah, for admitting it. That's sweet. You're honest. I like that.
No, I was just trying to fix something and it disappeared.
I thought my laptop is crashed or something, but thank you for telling me. Anyway, guys, so so what happens in obstetrics? Basically, the meaning, who knows the difference between obs and gynae? I have to ask the basics, guys. A teacher has to make sure everybody knows the basics. Who's going to tell me? What's the difference between obs and gynae? Yeah, Shaista.
Can I say OBS
Yes,
is
yes, yes, yes.
related to it's related to once we get pregnant, from pregnancy
Very good.
onwards, it's the obstetric period till the
Very
6 weeks after delivery, and gynae is all other part of life. I guess yeah, means
Yes. Very good. So basically, Dr. Shaista said, OBS is the part where you is the pregnancy part of the gynae, where you're actually pregnant, honey, when you're like actually like having a baby. Now, whatever happens to the baby, that's something we study in obstetric. What about gynae? Would anybody like to give me a better definition of gynae?
In gynae, we deal with the female reproductive system as a whole.
Very good. So well done, Aisha. So basically, gynae is all about women's health minus pregnancy. Okay, everything about the uterus, the ovaries, the 3 cool organs of the body. Okay. So let's talk about the history taking. Okay, now in OBS history taking, same structure. Okay, could you tell me your complaint? Doctor, complaint is that most likely in obstetric history, she might be complaining with a regular. So basically, obstetric cases mostly come as antenatal follow-ups, just a routine follow-up. Okay, or they might come as maybe minor bleeding is happening. I'm worried about it. Maybe it would come as I'm throwing up a lot. There's like hyperemesis gravidarum. These are the kind of complaints that you will address during obstetrics. However, sometimes obstetrics might come in a case where there's a result in front of you. Result will say that this patient has tested like negative for rubella. She is not immune to rubella. And then her blood typing is also Rh negative. So in that case, you have to explain to her, you'll have to counsel her. According to that, that's something we're going to learn today. Okay, first, let's talk about how to take a history in OBS, because it's going to be a long history. So it might get confusing, but what are you going to do? You're going to use my hack, honey. Listen, we have only 3 minutes, 30 seconds for the history. This is what I need to emphasize on. 30 seconds for the history. You don't have time, okay, to ask too many questions. Okay, be smart with your questions. This is what you're going to ask. When it comes to OBS history, H, spam, H is the mnemonic. It's a OG mnemonic. You won't find it in any other place. I made it myself, okay? Whereas PMS, TOSA, and ICE are like universal mnemonics. This is a little new, okay? So always ask whenever a pregnant patient comes to you, doctor, actually, I'm feeling sick. Okay, always do the OD para as I taught you guys, symptom inquiry. OD para shouldn't be O, D, P, A, R, A. It should just be like, okay, when did it start? Okay, was it sudden? All right. Thank you for talking to me. I can also see from my notes you are pregnant. Is that right? Yes, doctor. Okay, I am going to ask you, then you step into the structure. So be smart. OD para only, 1, 2, showing to the examiner. All you have to do is make sure that examiner is heard, that you know that you need to inquire about symptoms. That's another deal that even the examiner knows. We don't have that much time. So let's step into the world of the OBS questions. H, for how many weeks are you into the pregnancy? Doctor, I'm 20 weeks, 59 weeks, or whatever it is. Okay. So now, the symptom-related inquiry will depend upon which trimester is she in. Okay, so first trimester is how many weeks? Who's going to tell me? Have these things in your mind when it comes to OBS.
13 weeks.
Brilliant.
12 weeks.
13.
Well done. Okay, there's a whole debate going on. Is it 12 or is it 13, guys? So it's first trimester, 3
13.
months multiplied by 4. So 12. No? Okay, 13 for some reason. 12,
It's
13 doesn't
13,
really
yeah.
matter.
It's 13 actually.
Okay,
Yeah.
same. Very good.
Yeah.
Okay, second try starts from 12 or 13 to how many weeks?
Dr. Hasna, I have a really easy hack to, how I have remembered it. Like,
Okay,
for
please.
example, the first trimester is 13 weeks, right? So if you add 13 more, so it makes 26, right?
Wow. Why did I think of that? Sorry, that's genius. Very good. So
it's
26
going
weeks.
to
Are
be
we
like first trimester, yeah.
very good? And then third trimester would
No, no, no,
be
no, no. No. The 26 weeks is and above would be the third trimester, and in between them is 13. From 13 till 26, it's going to be like the second trimester.
exactly. That's what I wrote. Can you see?
You have right that. Oh, okay.
Okay. Above 26 weeks is going to be third trimester.
Yeah,
Okay. So
yeah.
keep this in mind when you're talking to her. So if the moment she says 20 weeks, you should know which trimester it is in. Okay. So everybody brainstorm. Who's going to tell me? Patient has presented you. She's saying, I'm 30 weeks pregnant. Go ahead. What is this? Which trimester?
Second. Oh, sorry, third.
Third. See, this is what I'm trying to get you guys to do is reflexes should be made now. Okay. Tell me, you guys are probably, what is this stupid exercise? It's so easy. No, it's not easy. You should have this because on the day of exam, your brain will be fogged. So these reflexes will actually save you. Okay. Patient presents to you. She's on 18 week of pregnancy. What trimester?
Second.
Well done. Patient presents to you 36 week. What trimester?
Third.
Very good. What trimester? She presents to you with 25 weeks. What trimester?
Second.
Well done.
Second.
What is the 8-week trimester? Very easy.
First.
Well
First.
done. So had our training done for our brains to think quick. Wait, that was actually, let's keep it close. Okay. Now, suppose she says she is in the early weeks. For instance, she is in trimester 1st to 2nd. So you can ask her about PV bleed. These are the symptoms you can inquire about. Vomiting, because these are usually the first trimester complaints. So you can ask, did you notice any kind of bleed from your front passage? So for you to say bleeding from down there, and better word for that is front passage. Okay, from now on, you're going to start using that word. And have you noticed any vomiting, doctor? Sometimes I get morning sickness. Okay, so it's normal. Okay, fine. When it comes to above 20 weeks, always remember to ask fetal movements. Did you feel any, did you move? No. Are you able to feel your baby moving? Yes, doctor. Okay, good. Then you inquire about H spam, right? SP, previous pregnancy. So is this your first child or have you been pregnant before? Yes, I have been pregnant. How many children do you have? Doctor, one more. Okay, could you tell me, was the pregnancy with them fine? Everything was okay? Any problems? No, doctor. Okay, that's good to hear. Have you had any kind of abortion or miscarriage? No, doctor. Okay, so the difference between miscarriage and abortion, who knows?
Miscarriage is something, I think it was, it is not in the like person's capability to stop it. Like it just happens.
Yeah. Very good. That's
And
close.
and
Mhm.
abortion is something that the person needs not to have a child. He's going to abort it.
Okay, I get you where you're coming from. Let's keep it simple. Spontaneous expulsion is miscarriage. Abortion is when
Yeah,
you involve, like, exactly. So Seher's
yeah,
was kind of right, but then we made it better word, and
yeah,
that's all we did. Okay.
yeah.
Now, have you had in the previous pregnancies or in the current pregnancy, have you had any high blood pressure or sugar? Who's gonna tell me when is high blood pressure is related to pregnancy? When is it fault of
After
pregnancy?
after
After?
20 weeks.
20.
Very good. Very good, Aisha. And sugar, if sugar is high at what, when, what's the cutoff line for sugar being high? All of you are junior, like all of you know this, like all of you are intelligent enough, knowledgeable enough. You guys are accomplished enough to be able to answer this question. There's nothing new in this. That's you can answer. What is the cutoff line? Some people are Googling or chat GPTing. Yeah, Seher has
No,
something.
I was going to, tag Dr. Aisha. She's a gynecologist and obstetrician.
Guys, I'm kind of stressed out right now. Oh my God, there's a whole professional over here monitoring me.
Yeah, she's
Yes,
a
Aisha.
consultant. Yeah.
Aisha, go
That's
ahead.
why I
Dr.
was quite, yeah.
Okay, Aisha, please tell us. What is the cutoff point? Yeah.
Basically, gestational diabetes is like chronic in the first trimester. If it is diagnosed, as most likely it is chronic diabetes in first trimester, because then we have to do HbA1c to diagnose, and we take the same cutoff, like the 20 weeks for
Okay, fine. Let's move on from this one. So H spam H, you guys know how many weeks? Symptoms like PV bleed, previous pregnancy, A for abortions, M for miscarriage. I'm so stressed out right now. Okay, there's a whole gynecologist watching me. Obviously, she should know better. But what I know about the sugar part, what I know is that if someone has never had diabetes before and while they're pregnant, their sugar is high, you test them out for the gestational diabetes. So there's no, so I don't think there's any like week cutoff, but I think Dr. Aisha knows.
yeah, it is like that, but in the first trimester, if we have blood sugar levels and it's raised, then we should do HbA1c to see whether it was previously as well or not.
Exactly. So basically first trimester. So there was no, like, I was just tricking all of you. Only for the blood pressure, there was a 20-week thing. But in sugar, if she's never had sugar before, but now she's having while she's pregnant, then we have a sign. It could be gestational. Okay. So whenever an OBS, okay, then you just quickly go for a PMAF dosa, very quick PMAF dosa. For instance, she's pregnant for the first time. She just came for a regular antenatal. You just do basic, okay, PMAF dosa and how are you? Okay. Now I'm going to tell you how to deal with a case. If someone presents you for this is a first visit. What's the other word for first visit? It's booking visit. Okay. Booking visit is basically when she's coming for the first time. Okay. So what are the questions you need to make sure you're asking when someone comes first time pregnant, she's excited about her pregnancy and she's just here for a routine antenatal thing. So always remember just 3 questions from person and family. So when it comes to the P history and the F history, the family history and the personal history, just make sure you are 100% asking these 3 questions. Okay, thank you for answering. You're going to ask her this H spam H. You're going to do symptom inquiry. If she has any symptoms, she'll say, no, doctor, I have no symptom. I'm just pregnant. I came for a regular visit. Okay. So could you walk me through how many weeks, PV, do you have any symptoms like this, and do you have any previous pregnancies? Okay, and blah, 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 and high BP sugar. Okay, done. Now you come to the PMF TOSA part and you do this. Okay. 3 questions from person. Okay. Suppose it's Alice. Alice, have you had any maybe shooting of your BP in the past? we're talking about not pregnancy related, just in general. Okay, for over here, we were talking about pregnancy related high BP sugar. Okay, that's the difference. Now we're coming to basic questions. Okay, have you had high blood pressure, sugar? Do you have any long-term medical conditions? Okay, no, doctor. Have you had any kind of previous issues with, maybe clots? No, doctor. Okay, good to hear that. Anybody in the family with similar conditions? No, doctor. Okay, and miscarriage you already asked. Okay, that's all. And then you just go for a DESA history. So DESA history is important in an antenatal case because you have to make sure she's taking good iron because her diet matters. No need, I think exercise, you can leave that question, but do ask her smoking, alcohol, diet, because honey, you have to stop her from smoking and alcohol when it comes to pregnancy. You have to kind of give her that advice. So most likely she'll say, no, I'm not smoking. No, I don't drink alcohol. And how's your diet like? Is it healthy? Yes, doctor, it's healthy. Okay, thank you so much. Okay, always remember one thing. I'm going to give you a huge hack that probably you guys didn't know. We are doctors. We are MBBS doctors. We are not expected to be dietitians. Okay, so if it comes to a point where she asks you, doctor, what should I eat? Don't think that, oh my God, I'm so stupid. Why don't I know the perfect diet to give her? Honey, you're not stupid. We weren't really taught a nutrition or dietitian subject in our medical colleges. We do have a minor idea, but whenever she asks about diet, just say, okay, I will refer you to a dietitian. They will be better be able to guide you and build you a routine, build you a whatever dietary diary or dietary timetable of what to eat. Okay, now how do you manage a first antenatal case? Okay, thank you so much for talking to me, Marissa. Okay, first things first, I'm going to run some tests on you. Okay, or you can, first things first, you can just tell her congratulations on your pregnancy. From talking to you, I think everything is good, everything's normal. I'm glad you're telling me there's been no symptoms. Okay, so first things first, I'm going to run some tests on you. Okay, these are going to include, what are the tests to do in a first antenatal visit? This is something you all should know. Routines. Who's going to tell me what is included in routine tests?
CBC, your creatinine, sodium, potassium, basically the LFTs and the KFTs.
Very good. What's KFTs? Okay. And inflammatory markers?
Hepatitis profile.
No, that's not included in this.
Blood
It's only
group,
CBC,
blood
LFT,
group.
RFT.
Yeah,
And
and blood group.
Blood group is important.
yes. So what you're going to do is you're going to tell her, we're going to do your routine test, yes, and your screening test. This is your, I was only asking about the routine part, by the way, guys. Okay, and now we're also going to run your screening for various infections. Okay, you can tell her if you like, but you don't need to tell her. We're going to do your screening for certain viruses. Okay, and blood grouping. Very good, guys. Thank you so much for it. I didn't add that over here. Blood groups, very important. BG, okay, blood group. And we're going to run an ultrasound to make sure your pregnancy is fine, to confirm what week you're in. Okay. Okay, doctor. All right. So for now, I do have some advices to give you. Okay. First things first, we're going to start you on folic acid. Up to 12 weeks, you can give folic acid. After 12 weeks, you can tell her to stop. And vitamin D supplements. All right. Now, the only dietary advice you should know in an OBS case, in a first visit case, is my advice to you is that try to avoid eating uncooked meat, egg, fish, and unpasteurized milk. Okay. Uncooked meat, egg and fish, unpasteurized, because these can cause those infections that are very that can for first trimester, those infections are going to be very, what do you call them, dangerous for the baby. Now, concerns. Do you have any concerns up to now? No, doctor, or yes, doctor, this. Okay. So if she's in her first trimester, you have to tell her, okay, we're going to follow you up in 12 weeks where your dating scan will be held. Okay, but if she's in second trimester, just say, I will do a regular follow-up. We will do a regular follow-ups with you. Okay, stay regular on your follow-ups. That's about it. Even if you're not able to say this part, honey, you will never fail the exam. Okay, these are just tiny things to add on. They're like cherry on tops. Okay, cherries on tops. No, cherries on top. But it doesn't mean if you don't say it, you're going to fail or something. Okay, but the only thing is, always remember important things. Important things, common things are the things that you have to have a good grip on. Not like weird, rare situations like, oh my God, the heart is not beating. When do I invite her for follow-up? How? That's too complex. Plab 2 is not that complex. It's not that deep. Okay. So this is a first visit. So whenever a patient comes to you with a first visit, all you have to do is make sure you ask the 3 questions. You go for the DESA history. And then when it comes to management, you make sure you talk about these 4 tests. These are the routines: screening, blood group, and ultrasound. Then you give her some advice, especially related to folic acid and vitamin D supplementation. If diet, you just have to advise her about this. Tell her to stop smoking if she's smoking, alcohol to stop at least during pregnancy, while if she is doing so. And any concerns, okay, thank you so much. At any time you have this safety net, bye. Now, this was just a regular OBS case, which is not a pathological case. There's no disease involved in this, okay? Who's going to tell me the structure of a first antenatal visit? Go ahead. This should be on your fingertips. Otherwise, when you try to go study on your own, you're going to cry. Okay, I show you that. If you don't
Okay,
listen.
can I do this?
Go
Can I
ahead.
do this?
Patient, if
Okay,
you're first
so
antenatal visit, what's the first thing?
that we need to ask 3 questions from person and family.
In the beginning, you're going to ask that.
No,
The
you just said
current
the booking visit,
claim
right?
first.
Yeah. This is the first visit. Tell me from structure from beginning. She's come to you, Alice is sitting, you've rapport yourself, and now you know that she's just her first antenatal random booking visit. She came.
Okay.
There's nothing going on. Okay.
Like
Tell me
how
first.
many weeks? How many
Very good.
weeks?
So you begin your whole questionnaire with 8 spam age. How many weeks? What's next, Seher? S?
And then we need to ask about the symptoms, like bleed from the front passage or vomiting. And if she's
Very good.
above 20 weeks, then we need to ask about the
Very
movements.
good. Very good. Go for P.
And yes, then we need to ask about the previous pregnancy and its outcomes. How did
Very
it
good.
went?
Very good.
And then any abortions or miscarriages,
No, okay.
and high BP, and there was the sugar.
Yes. So if she's had previous pregnancies, you have to make sure in the previous pregnancy, did you face any issue, for instance, high blood pressure or maybe sugar, anything like that? No. Even if she says previous pregnancies were fine, outcome was fine, I want you guys to include this question formally. Was there presence of high blood pressure or sugar in those pregnancies? I promise you, real life patients in front of me, they don't tell you. They think that high blood, yeah, I had a high blood pressure, whatever. You have to physically ask them. Okay, so make sure you ask them. Okay, next is 8 spam age questions are done. What's next? Now comes Seher. Seher, what were you saying in the beginning?
I was saying about the booking visits.
Yeah, what's next after 8 spam age? What's next?
3 questions from person and family.
Brilliant. Okay, so 3 questions in which you're gonna ask her what's the first question?
The high blood pressure and the sugar levels.
Have you had it
And
without the pregnancy? Yeah. Do you have any long-term medical conditions, for example, high blood pressure, sugar, and very important.
and then I think the other ones were there were some clot things in the lungs,
Very
legs, I
good.
guess. Yeah.
Any clotting disorders, maybe clotting, anything related to that, maybe leg clots or anything like that. Okay, whatever you want to ask.
Okay.
Okay, and then the
Okay.
third was no need to ask because you already
Um,
asked her in the AM. Okay. Now,
Okay.
coming to family, any similar case in family, maybe. Okay. Okay. Anybody in your family, the women, where did they have maybe high blood pressure or sugar in there during their pregnancy, especially your mother? No, doctor. Okay. These are booking visit questions. You have to go deep with these questions. Okay. Okay. And did anybody in clotting disorder in your family? No, doctor. Because why are we asking about clotting disorder? What are we so worried about?
There can be embolism because he's going to be pregnant, and there
And
was
there is
amniotic
another
embolism. No?
Risk of miscarriage as well.
Very good. Brilliant.
Yeah.
Clotting could be a cause of the miscarriage. What do you think is the disease we're thinking about?
yeah, it's
Phospholipid. There was this antiphospholipid.
Well done. I think Shaista said it. I heard Shaista saying it, but
yeah.
Sarah also very good. Everyone said it at the same time, so all of you were well done. Okay, but yeah. So APS is what we're suspecting when we ask that question. What's next? What do we ask next? Nest, whatever next.
The management, the DESA history.
Well done. That's very important in case of OBS gynae. So DESA is actually prioritized. And finally, you all were like, oh my God, we never prioritized DESA. Can we like someday prioritize it? Today is that day, guys. Good luck. Good luck. No. Well done. Okay. Congratulations. That's what I mean. So DESA, and I think we can skip the exercise part. We don't have time to ask that, honey. 3 minutes, 30 seconds. We can't do too much. Okay. DESA. Okay. Like DESA or whatever. So you can ask ask her the sad questions. That makes so much sense. Smoking, alcohol, diet. Could you walk me through your diet? Okay, is it healthy? Okay, that's good to hear. That's enough. You don't need to inquire, okay, tell me what you eat in the morning. Okay, what about night? Do you breathe? Like, what the hell? Don't ask her that. Just be like, and could you walk me through? Would you say your diet is healthy? Are you having enough meat? These are the questions you asked in diet. Okay. Now you're done with these were the only questions, my love. So listen, obs gynae everywhere. Any notes you try to study, obs gynae is going to be like massive. The questions are going to be massive. You're not going to include every question. Okay. And not everyone tells you this, that only ask relevant questions. So, got it? So this was, yeah. That. Now we're coming to management. Who's going to tell me what are the routine tests to do in obs gynae case?
Blood group, FBC, RFTs, LFTs, and the hepatitis profile.
Well done. So rather than this is my
And
hat.
urine routine examination as well.
Yeah.
Thank you for reminding me. Thank you for reminding. Well done, Aisha. By the way, routines contains the urine examination. Well done. That's why I was saying, what was the other thing? Well done. So, who's gonna tell me that? What was the question? Yeah. So never. I advise you guys to just say the word routine. This will save you a lot of time rather than saying CBC, LFT, RFT. Okay? Because to be honest, the patient in front of you does not even know what those tests are. What is LFT, RFT? So it probably he'll be like, what okay? So just keep it easy. We're gonna run some routine tests on you. And you already got the marks for those 5 tests. And we're going to do your blood grouping, honey. Very important. Why are we doing the blood grouping? Let's see who knows this.
For
RH incompatibility.
I didn't hear anyone, but I heard a conclusive, like I heard something you all of you said it together. It was right. Exactly. Something related to the RH situation. Well done. Okay. Blood group compatibilities, like even if there's a different blood group of the mother and the child, just the A part or the B part, even that can cause minor jaundice when the baby is born. There's also something we can keep in mind, okay? But for you guys, keep it simple, RH. I think Aisha knows best.
Yeah, the other one you are talking is ABO incompatibility. But in that case, jaundice is minor, yeah.
Well done, well done. So guys, Aisha is actually here and I'm just like, what if I say
No.
Okay, so well done. Blood grouping, and then we go to what do we go to next? Yeah, screening.
IUSG.
So what do we screen for today? Let's just
Viral
this is for
markers.
knowledge. You don't need to say everything. Hepatitis, very good.
HIV.
You can just say viral markers.
Sorry, Aisha, what did you?
Hepatitis B, C, HIV, and syphilis.
Very good.
Yeah.
Some more tests are also done during this whole situation. One more is called
Rubella.
Exactly.
Now rubella is not routinely recommended because mostly are vaccinated before. So basically these
But it's still, because in UK, people are coming from all around the world, so they still
I am
need
talking
discharge.
about UK guidelines. In UK guidelines,
Whatever it is, just a screening and your work will be done. However, in Plab 2, there is a whole case related to rubella antibodies coming negative. That's why. Keep this in mind that rubella is included in these, okay? But that's all you need to know, okay? See, what we need to know in Plab 2 is basic junior doctor level knowledge, okay? Extreme obs gynae, even if you don't know the fact that, okay, rubella is not included, that's also fine because, at the end of the day, we're only junior doctors. Aisha is not a junior doctor, so she should know these things. Okay, so let's go to the next case, which comes as pre-eclampsia. This is another case that presents in obstetrics only. Okay, how will the case present to you? She will present to you female as coming, and they're gonna say it in the prompt that you'll know it's preeclampsia. You won't really have to diagnose it. It'll just say it's like a 32-week pregnancy lady has come to you. Her blood pressure comes out to be 150/60, and urine has come out positive for proteins. This is said in the prompt. You will be provided with this information, so don't worry about diagnosing it. Okay, once again, you didn't hear it from me. Plab 2 cases are fixed. You did not hear it from me. So that's how it presents. What are you going to do in terms of when you enter that case? How do you talk to the patient? This is how you talk to the patient. Hello, I'm Dr. This. Could you walk me through same history? Have you had previous high blood pressure So you already, in the history I've provided you, the blueprint I've provided you, you're already emphasizing a lot on the BP. Even in the 8 spam age, even in the her own questions. Long-term medical condition, for instance, did you have blood pressure? Do you have hypertension at the moment? Chronic? No, doctor, I've never had a high blood pressure. So it's confirmed. But remember that in preeclampsia, you have to ask these questions. Red flags. This, you're going to ask, at the moment, are you experiencing any headache? No, doctor. Very good. Good sign. Any problems with the vision? Any tummy pain? Why are we asking about these questions? Let's talk about why are we asking about headache and vision. Okay, let's first talk about eclampsia. How can I expect you all to know? Maybe some people need a revision on eclampsia, okay? First, tell me, first thing is known as chronic hypertension, okay? Once you're pregnant comes the term PIH, called pregnancy-induced hypertension. Is pregnancy-induced hypertension equal to preeclampsia? Can you answer that for me?
No.
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 Well done. Okay. Pregnancy-induced hypertension, at 20 weeks, someone is having high blood pressure. That's about it. What is the criteria for us to call it preeclampsia?
Proteinuria.
Oh my God, well
Yeah.
done. So high BP with proteinuria, honey. I'm sorry to tell you, but like, yeah, this is not easy. Okay. So what do you do in a case of preeclampsia? The only one right answer for that is, what's the management for preeclampsia?
Dietary management.
No. Preeclampsia, admit. You have no option. You cannot let her go. If proteins are coming, what does it mean? What are we worried about? What are we worried about? Preeclampsia is a red flag, remember. Okay. What are we so worried about?
Eclampsia.
Eclampsia. Fits.
Exactly.
Fits.
Brilliant, guys. BRB. I just got someone's at my door. Sorry. I'm back. Okay. So pre-eclampsia, admit. Okay, the definition of pre-eclampsia is simple. Okay, usually the reason I'm going through this, there are gonna be people in this class that don't even know what preeclampsia, eclampsia is, but that's not something we're embarrassed about. It's okay. Especially guys, they don't take gynae seriously, just like we don't take male reproductive systems seriously. That's why they might not know what it is, just for you guys. So the preeclampsia is when there is, yes, high BP in pregnancy. Don't forget to say in pregnancy, plus proteinuria. Simple as that. That's the criteria to say, yes, she has preeclampsia. Okay. Proteinuria means, yeah, the high BP is actually like getting to her system. Like it's actually like gonna have an issue. Okay. So now you go for the reason why we're so worried when she has pre-eclampsia. We're so worried. This is a red flag. Why? Because we're worried exactly how you guys just said, eclampsia. Eclampsia is what we're worried about. So there's no such thing as eclampsia is the red flag. When she has eclampsia, then we'll admit her. Honey, what the eclampsia, she's gone. It's gone. Baby, mom, both gone. If she becomes eclampsia, who's going to tell me what is eclampsia?
It's basically preeclampsia, but with complications like seizures.
Well done. So high, what is this? Exactly. Copy paste, guys. This gets every time you add on a symptom. Okay. That's the game. So same thing plus neurological signs. That's why when we said headache, vision problems, that was us seeing, is she going towards like you get saying that's stressful for us. Like, do the delivery. Okay. So if someone has rather, why did I tell you guys the answer? If someone has preeclampsia, we will admit, yes. Will we do delivery or not?
Yes.
Okay. So when it's preeclampsia, we won't do delivery. When it's eclampsia or close to eclampsia, that's when we'll do the delivery. Okay. So the
Yeah,
only
in preeclampsia, we wait. We'll do the CTG if the baby is in distress.
yes, that's it. So what happens is that pregnancy-induced hypertension, sometimes in pregnancy, someone gets hypertensive because of some changes, placenta is implanting and some changes happen, okay? Now, if those changes, if she's not controlling her BP and it's getting worse, proteins will start showing up in the urine, okay? Because your blood pressure is so raised that proteins are squeezing inside your urine, okay? So it means her blood pressure is uncontrolled. That's a way of telling her blood pressure is uncontrolled, which means it's getting to her head now. It's going to go to her neurological system. We need to fix. Okay, if we can fix her BP in time, we can fix her. But if we can't fix her BP, it was already got into her head. She's saying, I'm having headache and some vision problems. It's going towards eclampsia. Honey, we have to deliver you, if you don't mind. Because see, now the baby is in danger. Now it's a question of your baby. We care about your baby. So eclampsia can cause the death of baby. Okay. So be very careful when. So basically, in this entire case, you're gonna ask her very important questions. Are you at the moment? Are you experiencing any headache? Okay. Any vision problems going on? No, doctor. And how about any tummy pain? Tummy pain usually for HELLP syndrome, but that's too intense. At Plab 2 level, don't need to know too much intense stuff. Okay. So any tummy pain you notice? Yes, doctor. No, doctor. All of these are just remember these are red flags. Okay. Admission is 100% you have to do. Okay. All right. Thank you so much for talking to me. And then you just go for the 8 spam age questions. And then you go for, thank you so much for talking to me, Rebecca. So first things first, I need to tell you, number one, diagnosis. Tell her the diagnosis. You are having a condition we called preeclampsia. Are you following? And make sure you tell her, guys, preeclampsia is equal to a heart attack. That's how serious you need to be in this case. Maybe not, we weren't made aware of how serious preeclampsia is because obviously we didn't do gynae, we're basic doctors. But I learned with time that preeclampsia is a very serious condition. Okay. When it comes to preeclampsia, you have to tell her like you're telling her about a heart attack. So, Alice, I need to tell you what you are having is a condition called preeclampsia. Would you like me to tell you what it is? It's basically a condition where there's high blood pressure and there is leakage of protein in your urine. Okay. This I want you to know. Make sure you orient the patient, guys. Don't hide from the patient the seriousness. This is a serious condition, Alice. Okay. But for that, we are going to have you admitted. Okay. How does that sound? Make sure you ask her, how does that sound? Okay, doctor, I can get admitted. Okay. And would you like to know what we'll do when you're admitted? Yes, tell me. So first things first, we're going to run some tests on you. We're going to test your urine. We're going to do your clotting profile and LFTs. Just remember the UCL, University College of London. Okay, just remember that. That's the best I could give you. U, C, and L. Okay, we're going to do these urine clotting profile and LFTs. Even if you guys listen to me very carefully, I'm going to tell you hack of Plab 2. Even if you don't say these 3 words, you will never fail the test. That's how Plab 2 is. But if you don't admit her, you fail the test. Okay, no matter what you tell her, no matter you tell her, if you're getting, it's worsening, come to the hospital immediately, make sure we'll give you blood pressure medication, we'll manage you. But if you don't say the word admit, it's screwed. You can mess up your case. That's how simple Plab 2 is. Okay. So you know what people do? The reason why majority fail is because they focus on urine clotting profile, LFT. They don't give a crap about admission. Nobody told them that this is the priority. This is not the priority. Okay, telling her we're going to do some tests on you, even that is fine. That's the beauty of this exam. Okay, and if you want, if you can remember ultrasound as well. Okay. Okay, then at the same time, very importantly, we're going to monitor your baby as well. We're going to run a CTG on you. Okay, and we're going to hear the baby's heartbeat and monitor. Most importantly, Alice, what we are going to do is we're going to give you some blood pressure lowering medication so that your blood pressure goes down. If required, we might need to give you a special medicine. This is called magnesium sulfate, but I will ask my senior. So here's the safety doctor thing, guys. Antidepressant can be prescribed without senior, and MgSO4. If you say I will give you MgSO4, fail. You won't exactly fail the station, but your management marks will go super down. Okay. Kindly don't spread rumors that, oh my God, if I don't get the diagnosis right, I'll fail it. When I say fail means marks go down. But your data gathering IPS total marks, if it's fail or pass, that's something they'll calculate. Okay. And at any time, Alice, we feel like you, the baby's heartbeat is going low, or anything we feel like is going wrong, we might have to deliver the baby. Okay. Doctor, I don't want to get admitted. Most likely the patient will not understand the seriousness of it. No, doctor, I don't. Doctor, actually I have to go back home. My husband's waiting for me. We're going to the park or whatever. Oh, I completely understand. Don't disregard what she's saying. Don't be like, no, this is very serious. Don't ever do that. That's not okay. Okay, I'm teaching you these things because I note n number of stories making these mistakes. N number of people going in Plab and being like, no, this is what you're going to do. So as a junior doctor, my hack to you guys, golden hack, do not dominate the patient. Okay. Always say, oh, I completely understand where you're coming from, Alice. I'm sure that, you weren't expecting to hear this today. But sorry, Alice, I need to tell you this, that preeclampsia is a very serious condition. And it is serious to the extent that if we don't stabilize it, it might lead to something called eclampsia, which can result in you and the baby both's life at risk. And when you tell her that the life is at risk is when she'll be like, okay, I'd love to get admitted. So she's waiting to hear that someone's going to die. Then only she'll get admitted. Okay. That's the whole thing. So use that weapon. Only if she asks. But if she doesn't ask, you just need to go for the structure I gave you. Number 1, we'll run some tests on you, further tests on you. Okay. We'll do monitoring of your baby through CTG. And the most important part, Alice, is we need to bring your blood pressure down. Are you following me up to now? Yes. We're going to give you through your vein, we will give you some blood pressure lowering medication, which is very necessary for you right now. Okay. The third thing is, Alice, we need to prevent this from getting worse. And for that, we might need to add on medicine called magnesium sulfate. Okay. This is a medication that can, fix any dangerous situation. But this is something I will call in my senior for us to decide if you want to give it to you. Are you following me up to now? Yes. And lastly, Alice, I need to tell you this, is that if at any point we feel like there is any instability in your blood pressure, or maybe baby's life is a little risky, we will have to deliver the baby immediately. Does that make sense to you? Yes, Alice. And I'm very sorry, Alice. I know this is a very difficult time for you. I assure you that we will try our level best, and everything hopefully will be okay as long as you get admitted. Okay. How does that sound? Oh, that sounds lovely. Okay, so don't keep it long. I know that preeclampsia is a longer, there's a lot of things to tell, so I made them short. If you try to study gynae on your own, there's going to be this and most importantly, you have to make sure she has an idea that delivery might happen while she's staying here. Because if you don't tell her any of these things, for instance, you don't tell her delivery might when she's in the hospital and you're like, we need to deliver you. And she's like, what the heck do you mean by deliver me? And she'll get all upset. So make sure you're mentally preparing. These are the beautiful things you need to tell her that can never, you will be like, the examiner will he'll get up from his seat and he'll clap for you. Like, this is a good doctor. Okay. So that's how I've made these structure so that the examiner has no option but to stand up, and he won't actually do that. But yeah. Okay. Now let's talk about what are the other types of obstetric cases that come. Some game rules in OBS cases. We all know how to take an OBS history now. Okay, we're good at that. So for everything, apply the same OBS history, but change the treatment parts. Okay, I'm going to tell you the treatment. Now we're going to talk about a little bit of a difficult case. Why do I say it? Because it's going to test how beautifully you explain something as short as you can. Are you guys ready? Now, patient comes to you, first thing, she will come to you with previous to miscarriage. She is on her booking visit at the moment. The only thing you'll do the same history taking. And at the end, when you ask her about her concerns, she'll say, doctor, and you'll be like, yes, doctor, do you think I'll have another miscarriage because, someone told me, or someone in my family, they had something, a disease, I don't know, APS. So she'll have an idea. So do you think I should get tested for that? So this is, keep in mind, she has had 2 miscarriages in the past. You know what? Give me a minute. Let me bring that case so you guys understand better. 5 Okay, guys, we're back. So let me show you how the case presents so you have a better idea, because I feel like if I'm not able to explain, well, let me just show you the whole prompt, okay? This is how you're going to be. You're going to be outside the cubicle. You're going to have 1 minute to read your prompt, and the GMC recording will say, begin. And this is what you're going to read. FY2 in the OBS-GYN department. Audrey Jones, 24, has come for a routine antenatal follow-up. Mrs. Aurea has had last 6 weeks ago, which means this is her booking visit. Done. You all know the booking visit structure now. Well done. So you're like, yeah, bro, I'm doing this. And then you enter the cubicle and this is what she says. Yeah, doctor, had when you ask her the miscarriage question, she said, I had 2 miscarriages, doctor, at 8 weeks. And she'll be sad. Look, look, look. This is instruction that the simulators are given. You are sad and anxious. Doctor had 2 previous miscarriages. And what whenever miscarriage comes, you have to ask, what week did you have that miscarriage? And she'll say 8 weeks. Okay. And this was how long ago it was? It was 2 years ago. Okay. At the moment, blah, blah, blah. Are you taking any medication, smoking history, and you did a pregnancy test? Okay, whatever, LMP, whatever. Okay. Why you have come for a, you are fit and well. After 2 minutes, you went to see the GP, but nothing was found. GP simply said, I should try again. So her question will be, doctor, just look at this. How can I make sure I do not have another miscarriage? This is going to be her concerns. She's going to be given these concerns. Okay. Doctor, is everything going to be fine? Is it going to happen again? So these are the things that she will ask in the cubicle. Her concerns are going to be this. Okay. So make sure you know how to address all of these questions. Okay. So in this case, you are not going to worry about the APS. This is what you're going to tell her. As you have an equal chance of a normal pregnancy. Okay, so this is it. There's no such thing as because she had 2 previous miscarriages does mean that now she's going to have another miscarriage. Just because we know that 3 miscarriages is APS. No, she's had 2, so there is a chance maybe 3rd becomes fine. If the 3rd is not fine, then you go for the APS testing. So you've got equal chance of normal pregnancy. You've had only 2 miscarriages, okay? The chances of having another only increases after 3 miscarriages. So this is how you will address her concern. This is what she's wanting to hear. If you don't say, so if there was, hopefully not, God forbid, you have a 3rd miscarriage, only then we'll go for the further testing. For now, you don't need any further testing. Are you following me? Okay. So usually we do those further testing for a syndrome called antiphospholipid antibody syndrome. But for now, I don't want you to worry about that. Okay. And then you go about exactly what I taught you guys. Okay. Alcohol, exercise. See, that's what I'm saying. Look, in gynae, if you see all the notes, they're gonna be, this is how much they look at this is just half of the notes that they've given. There's another whole page written about the whole management. So this is what I'm trying to teach you guys. This is 10-20 things, but what are you going to do? Only among those things, you're gonna go for telling her about these, and you're gonna be safe enough. And the only thing you're going to add on in a 2nd miscarriage, 3rd miscarriage case, you're just going to tell her reassurance is what you're going to add on in that case. That's all I'm trying to tell you. Okay. No case comes in Plab 2 where it's going to be 3 miscarriages and then you'll have to do APS. It's always going to be 2 miscarriage case. Okay. Then comes a concern about, she'll be like, doctor, yes, I'm here for my first antenatal visit, but I have a concern. Someone in my family has chicken pox. Should I be worried? So the only question is, what are you going to ask in case of chicken pox? Plab 1 people would know the answer to this. Questions to ask?
If she's had pox before.
Very good. Childhood pox. She'll probably say yes. Then you know she's safe. Okay, have you had it now? If she says, no, I don't remember or whatever, then we'll do her whatever we were taught. What were we taught? We were taught one thing. And just remember one more thing. Even if she's in exposure of with a person of chicken pox, you can tell her that it's okay. You're safe. Nothing dangerous will happen to the bee. Just make sure you include, have you had chicken pox in your childhood? Which is most likely she'll say, okay, yes, I did. Okay. A patient comes to you, she'll be on a captopril medication. So she'll be like, doc, you have to ask the same questions, but the only concern will be, doctor, I'm taking captopril for it, or maybe I'm taking some other medication for it. The only thing you need to do, you have to tell her, oh, we'll have to change your blood pressure medications if you're trying to get pregnant, because that is a safe medication for the pregnancy. That's about it. And what is this pregnancy safe BP medication? Either labetalol or methyl dopa. We're going to refer you to a OBS-GYN. She's going to be better able to prescribe you. If at any time you feel like you're not able to prescribe, you're not able to call, just tell her, I will refer you to the specialist, okay? They're going to be better able to put you on a medication. Okay, how does that sound? Okay, they will put you on a pregnancy safe medication. So you are safe. It doesn't matter that maybe you didn't remember the medication, but you did your safe thing. That the safe thing was in this entire case was the fact that you know that this medicine is not okay for pregnancy. Okay, now let's come to the difficult part. Okay, I'm ready. So the rubella, what do you call it? The rubella explanation. Patient comes on her screening test. The test result will show she is rubella negative, meaning she has no antibody against rubella. Who remembers that when we were kids, we got MMR vaccine, which means she did not get that MMR vaccine, which means we need to tell her some things. There's some advice we need to give in case of rubella. Why? Rubella is dangerous for a baby. Okay, so that's why you need to tell her a couple of things. So it's a visit and you tell her, okay, so I have, and you just have to see her test results. So in that case, obviously test results have been given to you. So you're not going to say that I would like to do your routine test screening and ultrasound. You don't need to do these things because they're done. The test results are in front of you and it says RH negative, rubella negative. Okay, you think rubella is negative, infection negative. Woohoo, no. This is rubella antibodies. They are negative, which means she's not immune to rubella. So what do I need to tell her? All right. So Alice, I need to tell you something important regarding some screening tests that have come back. Okay. You have come to be non-immune. You have tested non-immune towards a virus we called, wow, rubella. Okay, let me explain to you further. Okay, first things first, rubella is just an infection that might cause fever or rash in a person if they're not vaccinated, if they're infected with it. Okay, you are not immune to that virus because usually we get a vaccine as a child, make us immune to it, but you're not. Okay, are you following me up to now? Yes, doctor. Okay, so the concern with this is that during pregnancy, we cannot vaccinate you, which means we cannot really do anything about it. We cannot give you a vaccination to make you immune. Does that make sense? The actual problem is, Alice, is that if you were to be infected with rubella in your up to your first trimester, up to 16 weeks, you can say 16 weeks, up to 16 weeks, if you contract rubella infection, it is harmful for the baby. And in 90% of women, we tell the women to end their pregnancy because it can lead to congenital defects in the child. Are you following me up to now? Yes, doctor. Okay, so this is a serious condition. However, what we can do to prevent is try to, at least up to 16 weeks, try to avoid anyone that's, sick, try to stay home, try to stay, wary of any kind of infection. And at any time you develop fever or rash, just come to us immediately. Are you following me? Yes, doctor. So this is the rubella explanation. So remember, guys, rubella, if contracted up to 16-week pregnancy, it is harmful for the baby. We usually have to tell the ladies to abort the pregnancy if they get rubella in 16 weeks, because it can lead to congenital, very bad malformations in child, and he becomes incompatible with life. So there's no point in, you get what I'm saying? So, so I saw there were like there was a whole paragraph written on rubella, and I've even had people in SBTs try to tell me, like, give me the explanation. He was able to do it. That's when I decided to write it down in bullet points. When you write it on bullet points, you know the more important things to tell her, and you just tell everything in one line, not more than that. And that becomes easy. So guys, whenever there's a huge hack, whenever something's too difficult to speak about, you don't know how to say it, explanation is difficult, write it in bullet points. Who would like to go ahead and try to explain me the rubella non-immune situation?
Can I try?
From what? Yeah, go ahead.
What would be your name?
Go for Marissa. I don't know why I keep saying that name.
Okay. All right. Okay, so Marissa, we ran some tests on you, and I have something important to discuss with you.
Okay.
All right, so your blood tests, it reveals that you don't have antibodies against a bug called rubella. Are you following me?
Okay, doctor.
Okay. Rubella, do you know what rubella is?
I'm not sure actually.
All right. So basically, rubella, it's a bug of sort, okay, which causes an infection, all right, in people,
Okay.
which might cause one to develop fever or rash, all right?
Does that make sense? Okay.
Okay. So basically, your test shows that you don't have antibodies against this bug, which means you are not immune to this bug. Okay.
Okay.
So now what happened? Now, what we are worried about is that since you're pregnant, and if you do end up contracting this infection, especially within the first 16 weeks of your pregnancy, it might be very harmful for your baby.
Oh, okay.
So if a lady is not immune to rubella, we're afraid we can't even offer vaccination to such women.
Okay.
Okay.
What can I do, doctor?
Yeah. So what we would advise you to do is at least up to the first 16 weeks, just avoid going out, okay? Avoid coming in contact with anyone who's sick, okay? Just try to take care of yourself, okay? Just be wary of any kind of infection within the first 16 weeks.
Okay.
Okay, how does that sound?
That's amazing. Okay, that's it. Very good, Arshi. That was brilliant. See, look. I'm gonna show you guys the. Sorry, I was looking for notes. Let me show you guys. So I'm gonna show it to you now. Okay. Great. Wow. Sorry about that. Let me just show you guys how this presents. Just watch. Mary White, she's 14 weeks pregnant, RH negative, rubella non-immune. It looks like it's not a big deal, and you're just like walking through it. S syphilis, okay, good, negative. Hepatitis and negative. She's blood group A, okay, good for her. So I know RH negative, and she's non-immune to rubella. So exactly the way Arshi said it, this is exactly how we're gonna tell her. Just watch. In regards to what we checked for, we checked if you're immunized against rubella. Unfortunately, it showed that the page is gone. Wow. So I don't know why life is so difficult. Okay, let's do this again. You are not immunized against the infection. Okay, I hope everyone can see my screen. You are not immunized against an infection called rubella. So you're not protected. That can be a serious infection in pregnancy because it causes damage in 90% of if the pregnant woman catches in 16 weeks pregnancy. It's not advisable to offer immunization during pregnancy and just avoid people with infection, rash, fever. So this is big fat points that you needed to tell. That's a huge paragraph, but you have to do it in bullet points, and always remember there's a timer ticking. So in format, try to complete this explanation in 1 minute. So the amount of time that Arshi took, I think it was perfect. She did not extend any explanation. That's what I love. Don't extend, don't over talk, because you'll start stumbling upon your own words. You will start confusing yourself. Okay, so now we're going to come to what are we talking about? RH negative. Now let's talk about the situation of RH negative. What do you tell her about the RH negative situation? Let me also show that to you in the form of notes. Let me do what other academies are doing. I'm so rude. I'm always like roasting. I'm so rude. Okay, where the heck are the notes, guys? Yeah. So RH negative. Let's see how to explain it. The other blood test was to check your blood group. Your rhesus status was done. It showed that you have a type of blood called rhesus negative, which means if you have a baby who's rhesus positive, your body can form antibodies to fight the red blood cells of the baby. That is likely to happen in the future pregnancies. And to prevent this, we offer anti-D immunoglobulin, which neutralizes the antigens and enter the mother's body. This can stop body from forming the antibodies, and this will be given to you in the 3rd trimester. That's about it. So you need to explain all of that and I just want to show you how bullet points are so helpful. Just tell her. Make sure you ask her in this case that what's the husband blood group. Even if you ask the husband blood group, you can always ask while you're explaining. Okay, could you tell me your husband's blood group? Yes, it's positive. Oh, okay. So what I need to tell you is that you have come out to be blood group negative, which is called rhesus negative. Are you following me? Yes, doctor. Okay. So basically what it means is that sometimes when you are negative, and because you're telling me your husband is positive, it is possible that your baby might also end up having a positive group, which means you will make some fighting agents against the positive group. Are you following me? Yes, doctor. So just to prevent those fighting agents, we are going to give you anti-D immunoglobulins. Okay, these are just something that will prevent you from forming those fighting agents. Does that make sense? Okay, and we're going to give you these in the 3rd trimester through your veins or through an injection. Am I making sense? So these two, in the whole case, you have to take these two things. It's going to take a lot of time. That's why be very wary of your time while you're taking history. Don't ask too many history questions and keep this explanation and keep the rest of the explanation short. For instance, no need to tell her about too much diet, too much smoking. Like, keep it short. Just tell her general advice. And apart from that, make sure you're eating healthy diet and try not to smoke. And no, if she's not smoking, don't say that. Have a healthy diet and keep regular with your antenatal follow-ups. Okay, we're going to be here for you. At any time you have this disease, come to the hospital immediately. Okay, we're done with this. So these are all the variants of obstetrics that might come. Okay, if I'm missing a couple of variants, probably because they're too easy. And like, these are the things I really wanted to discuss. As you can see, this is how cases come in a gynae. Yeah, I already pasted this. Why did I show you guys? So sorry about that. Okay, so we're done with obstetrics. I think that was it for obstetrics. Mostly the cases of obstetrics are always going to be either first visit, okay, just a general review, or maybe 2 miscarriages of the first visit. You have to just satisfy your concerns, or it could be a first visit with a rubella coming non-immune, RX negative. Okay, this might come, or there might be a pre-eclampsia case. Okay. These are major cases of what called the obstetrics. Okay, so no need to worry. What if this comes in the form of eclampsia? What if like, what do you call placental abruption comes? What if placenta previous? What did I tell you guys? You didn't hear it from me. They won't come. Okay, let's go to gynae. Let's talk about health, and let me give you the best hack to nail contraception. Because I know contraception, it's just too much. There are too many ways of contraception, how to memorize everything. Let me make it easy for you. Okay, so first things first, we all know there is a form. Okay, we'll talk about that later. Okay, let's talk about what are the contraceptions. So usually a patient will come to you with contraception with the following concern: doctor, I want contraception, but I want to decide. Please help me. This might be the case. Okay, so what you're going to do, you should have memory of the contraception. So some things in Plab 2 you have to memorize, but once again, in Plab 2, the memorizing will never be paragraph, huge, boring, difficult memorization. It will always be easy memorization. So let me just take it far because I feel like people are seeing a very zoomed in version. Okay, guys. So first type of contraception, and I will rapid fire you with these questions. The first type of contraception, guys, we have is a daily contraception, weekly contraception. Write it down in your notebook. Don't copy my table. That's not going to benefit you. Do it the way I'm telling you, step by step. Write down there's a daily contraception, there's a weekly contraception, there's a 3-monthly contraception, 3-year contraception, 5-yearly contraception. So daily, I'm going to memorize it with you. So I can show you guys it's possible to memorize this. So daily, weekly, 3-month, 3-year, 5-year. That's once you fill that out, now you should know the daily contraceptives are always going to be pills. The only daily thing you can take is pills. Remember the category, what in daily, what is the route of administration? Okay, done. The weekly ones are going to be, I need to see, I'm sorry, I forgot, patches. So patch laid under your skin or over your skin like a bandage. Weekly are always going to be package. Package, what? Patches, sorry. 3-monthly will always be injection, honey, injection. 3-monthly is going to be an injection. 3-yearly will always be an implant. Okay, how is implant different from a patch? Implant is proper embedded into your skin. The doctor has to place it. Patches you can do yourself, like nicotine patch. You just place it over here, you stick it like a bandage. Implant needs to be implanted. You know how a pacemaker needs to be implanted, just like that inside your skin. They put it inside your skin. Okay, so it's there. 3 yearly is an implant, and 5 yearly are intrauterine devices. Now you already know. For instance, like it's a whole like contraception is like a whole 10-page argument. Like 10 pages, you're gonna learn a lot, but 10-20 minutes of you trying to memorize this, I've already told you in this table in 10 seconds. Okay, so that's how I make stuff easy. Okay, so once again, if we go through it, what are the contraceptives available? Daily, weekly, 3-month, 3-year, 5-year. Easy. Who's tell me what is the 3-monthly? What is the mode of route of administration?
IM
Intramuscular.
injection. Yeah.
Very good. What is the mode of injection of 3-yearly?
Implant.
3 year implant.
Well done. Aisha, what are you saying?
Implant. Yeah.
Good. Aisha, tell me, what is the route of administration of?
What?
What?
I can't hear you.
Okay, I said, what is the route of administration of a daily contraception?
COCPs and POPs.
Very good. So by mouth
Oral.
or pills. Okay. Who's going to tell me weekly way of contraception?
Patches.
Patches.
Well done. So the reason you should know this is because what's her name? I forgot her name. I literally forgot. Alice is going to want you to tell her, because any patient that comes to you will always want to, okay, like we have to like get an injection out of it. See, people are really worried about these things. So you should have an idea that if you take it daily, then it'll be like a pill. That's a good thing about it. If you take it like, oh, if you want a long-term contraception, then you'll have to go for more invasive like injection or implant stuff for intrauterine. Okay. Now let's talk about the durations of each contraception. Okay. Duration of a daily contraception. What the heck? Wait, what did I just say? Daily is daily. That's the duration. Okay. Now let's talk about the failure rates of the contraceptions. Okay. So you can do 3, 2, 1. No, wait, it's 3, 3, 2, 1. Okay. So it goes like 3 and 1,000, which means if every 1,000 people, 1,000 ladies taking these pills, among them, 3 will still get pregnant if they take the pills. So that's its safety, or that's its failure rate. Okay, so 3 in 1,000. So you should be able to tell her that. Be able to explain what I just explained. So doctor, like how many chances do I have that this contraception fails? Oh, the failure chances are 3 in 1,000, which means guys, is it just for Arshi that my voice is freezing, or is it for everyone?
No, it's your voice is freezing.
No, oh, I'm so sorry. Because I'm
in between, it's getting cut off, like you're freezing in between.
oh
Yeah.
shit. What do I do about Okay, you know what? Let me restart my Zoom. I think Zoom is overwhelmed.
Yeah.
Okay?
Okay.
Okay, I'm making you the Arshi, I'm making you the host, okay? And I'll be back. Then you give me back my host.
No,
status.
I'm very technologically challenged. Please give it to Dr. Seher. She knows what's up with the Zoom. Don't
Okay.
take responsibility.
Seher, will you be able to do it when I'm back?
Yeah.
Okay,
Yeah.
okay. Tell me. Please tell me I'm not freezing.
Um, Yeah, till now you're not. Let me
Okay,
make
now
you host.
let me speak. Okay, we're doing contraception. Am I freezing in the contraception because we have a daily, weekly, monthly, 3 yearly, 5 yearly, 15 yearly? What's up? Did I freeze?
No, absolutely fine. Absolutely fine.
Thank you, Seher. You're the best. Instantly, Seher made me the host. Brilliant. The Arshi is technically challenged. That was so funny. Like, I ended the call and I started laughing. What was that? Arshi is technically challenged, guys. Okay. So firstly, we have from until when, like, when did you guys stop hearing me? I'll start from there again.
Failure rate.
About the failure rate, yeah.
So patient will 100% ask you, okay, I can take the pills, doctor, but what are the chances for failure? So that's when your 3 in 1000 comes. You're going to tell her, you'll have to explain to her that for basically what it means that for every 1000 pregnant women that are, sorry, for every 1000 ladies that are taking these pills, 3 get pregnant. So it's a 3 in 1000 failing rate. Does that make sense to you? Yes, doctor. So what about the failing rate for implant, doctor? Oh, that is 1 in 2000. Okay, which means for every 2000 lady, 1 get pregnant. So implant is quite good. Okay. Oh, okay, doctor. So she might ask these questions. Okay. So you should have at least an idea. So what is the failure rate for oral contraceptive? It's 3 in 1000. Weekly, same. 3 in 1000, then 2. 2 in 1000. The only thing now you need to change is 1 in 2000. Okay. So let's talk about the 5-year device. Myrina. Just remember the IUCD, 8 in 1000. Okay. Wait, no, Myrina is better. So 2 in 1000. So 2 in 1000. So Myrina is copying the Depo-Provera IM injection. Okay. So let's all try to memorize again. Okay. Who's going to tell me? So what is the failure rate for OCPs or oral contraceptive, meaning daily? Oops.
3 in
3 in
1000.
1000.
Billion. 3 in 1000. Tell me the failure rate for weekly.
3 in 1.
3.
3 in
Same,
1000.
3 in 1000.
Billion. Tell me the failure rate for 3 months.
2.
2
2
in
in
1000.
1000.
Good. You guys are using that technique. Okay, what is the failure rate for 3 years?
1 in
1.
1
2000.
in 2000.
Great, well done. And what is the Myrina failure rate?
2 in
2.
1000.
2 into 1000.
Good, very good. And what is the what?
8 into 1000.
8
Then-
in 1000.
IUCD.
8.
Now let's make it confusing. What is the failure rate for a contraceptive that you take through injection? Go ahead, answer that.
3 in
3
1000.
into 1000.
2 in 1.
No.
Sorry, it's
2
Depo.
2 in
into
1000. 2 in
Oh, yeah.
1000.
Depo-Provera.
Damn, guys, that's amazing. Is it 2 in 1000? Because
Yeah.
Yes,
It's 2 in
2 in
1.
1000.
Intramuscular injection is Depo-Provera. So yeah.
so proud of you guys because I did not remember that. Even I'm suffering. Okay, what's next is you guys tell me what is the failure rate of patches?
3 in
3
1.
3
in
into
1.
1000.
Brilliant. What is the failure rate of a of a implant?
1 in
1.
2000.
1 in
Just
2000.
keep in mind, implant has the best rate, like the best,
Yeah.
not a best, but like the best, whatever, accuracy rate. So it was 1 in 2000. Okay, then what the heck is with what about the copper device?
8 in
8.
1000.
8 in 1000.
Very good. What about the like oral contraceptive pills?
3
3 in
ratio.
3
1000.
into 1000.
3 in 1000. Okay. Now, who's going to explain me what does it mean by 3 in 1000 in simple words?
So every
That from
1000 women
the
taking the contraception, only 3 get pregnant.
That's brilliant. Who else was trying to speak? I want you also to try to ace your
it was
definition.
the same. Whatever Dr. she said, I wanted to say the same.
Very good. You just said you also get the exercise to say it, okay?
Okay, so out of 1,000 females, only who are taking the oral ones, only 3 can get pregnant.
Very good. So you should have an idea on how to explain it in 1 line. Once again, 1 line is the 1 line hack situation is a thing, okay? Why the heck is this here? Let's take it. Oh my God.
What happened?
Nothing. There was just something extra on my board. Okay, ready? Now she will ask you about the side effects. That's where she'll want to make a decision. Remember, all these three first modes of interception are interception. All like the four modes are intermenstrual bleeding is all you need to tell about them. And for the 5-yearly devices, we all know the two important side effects, ectopic and PID. What the heck is PID?
Pelvic inflammatory disease.
Well done. Okay. So for these two, you have to make sure that, okay, doctor, I want a long-term contraception. 5 years, this is your option. What are the side effects of it, doctor? It's basically there are chances you might get an infection, something we call as pelvic, and in the future, there might be chances for you to get a pregnancy outside it, but these are just like rare side effects. But I want you to keep them in mind. Okay. So ectopic pregnancy, PID, done. Now that we know the entire table of contraception, we've learned 3 hours worth of studying ourselves in, I don't know how many, 10 minutes, okay? Now, please help with overview of failure rates again. Okay, so who would like to practice their reflexes?
Me.
Go ahead, Seher. So I'm going to ask you table. Let's make our own table again, just for NK. Mr. NK, yeah. So first things first is Seher, what was the contraception? What was the failure rate for daily contraception?
It was 3 in 1,000.
Well done, 3 in 1,000. Which means, what does it mean? That it means that for every 1,000 women that are taking oral contraceptive, 3 will still get pregnant despite being on them. So that's a failure rate NK. Okay. Now, Seher, tell me, if we're taking intrauterine devices, what is the failure rate for Myna?
It's 8 in 1,000.
Well done. So for copper, it's 8 in 1,000. And what about Myrina?
It's 2 in 1,000.
2 in 1,000 is shared by another mode of contraceptive. Who is that?
IUCD and Myrina.
Depo-Provera.
The Depo-Provera. The intramuscular.
Yes. So it's the what monthly? How
3
how
months.
well done.
3
monthly.
months.
3 monthly has the same failure rate. 3 monthly, which is the injection form, is 2 in 1,000 as well. So which contraceptive is this reversed in? If you know, you know.
What? I did not get your question.
In which contraceptive you reverse this situation?
I have no idea.
I think you're talking about implant 1 in 2,000.
Yeah, well done, Aisha. So, Aisha, what is the duration of that contraceptive?
3 years.
Well done. 3 years. You have the 1 in 2,000. You just reverse the whole situation. Okay.
Oh, okay.
Yeah, you get it? Okay. I know it was a confusing question. Okay, Seher, what is left?
Weekly
Well done.
patches.
What's their failure rate?
3 in 1,000.
Okay, so now Dr. NK, so daily, so you can memorize this like this. Dr. NK is 3, 3, 2, 1. 3, 2, 1 basically, but 3, 3, 2, 1. Okay, and then this you just have to memorize that Myrina is same as 3 monthly. If you can't memorize that, just remember Myrina 2 in 1,000, but this 8 in 1,000. Some things you have to memorize. I can't really be like, there's a shortcut to memorize 2. Like, come on, some things everyone can memorize. Okay, so I think my question is, are these all? Is there any contraceptive I'm missing?
No, it's done.
Got it. So these are contraceptive. Okay, which contraceptive has a side effect of intermenstrual bleed?
Everyone except the 5-yearly.
Very good. So except this guy.
Even with the copper IUCD and these, there is still we can talk about intermenstrual bleeding with copper IUCD as well.
You can also do that. Very good.
Yeah.
But just because we have 4 minutes, we try to mention the main things first. Ectopic and what's the other thing? PID. Okay. Because yes, if we were like in a proper setup, we would definitely do IMB also. But I think the priorities in Plab 2 is to tell the main things, which is ectopic and IMD. That's why I didn't mention IMB. Okay. So this is the whole scene for contraceptives. Now let's talk about What are now COCPs have more significance than just an IMB, okay? Let's talk about when you decide to not give her COPP, wow, COCP. Just remember these conditions. Don't forget these. If the girl had migraines in the past, if the girl has clots in legs and lungs, if the girl is above BMI, a certain BMI, you cannot give her a contraceptive, okay? Or BT, like for instance, her BMI is above 30, so always do BMI in contraception. And then cancers, like anybody in the family with ovarian and breast cancer. Okay. So what are the contraindications for when can you never give us? So in the daily contraception, we have two types. We have either a COCP, a covered contraceptive, or just a progesterone only pill. So how do we decide, should we give this or should we give this? So the decision making lies in the contraindication of COCP. If she wants a oral medication, she wants a daily contraceptive, but she has migraine, DVT, or cancers in the family, then you go for POPP. So you get I'm saying how to make these decisions. So that's how simple it is. COPP. Why do I keep saying that? Okay. Number one rule. I wrote this in the last class, which thank you so much I wrote, because so every time a patient comes to you with contraceptive advice, always rule out pregnancy, because you always have to ask her, what was your last menstrual period? So in any case of gynae, always remember same basic structure that I taught you guys, just add on a gynecological history. What is the gynecological history? When it always starts with the LMP. When was your last menstrual period? What are they regular? Regular meaning, is the period coming after 28 days every time? That's the regularity question. And then is the amount of bleed question to decide whether it's menorrhagia or not. Okay, menorrhagia has nothing to do with regularity. So remember these basic terms. Menorrhagia means heavy bleeding. So and is your bleeding fine, or is there any heavy associated? So heavy bleed is for menorrhagia question. And then you ask her, do you take COCPs already? Are you taking, not COCP, sorry. Are you taking any contraceptives already? At the moment, doctor, I'm taking maybe saying I'm taking COCP, but I want to change it to something more like long term, because I don't like eating pills daily. So this is so important to know what her concerns are, what her choice is. Okay, I understand. Then you can ask contraceptive related question. For instance, you don't need to, because she's already taken COCP, you can ask DVT, migraines, and all of that. But for long term, I don't think there's much questions you can ask. Okay, thank you for talking to me. Coming to the contraceptive part, that you want to make a decision of the contraception. Okay, let me lay it down for you. Could you tell me, you are wanting a long-term method of contraception, right? Yes, doctor. Okay, so we have one contraception available for 3 years long, and then there's one for 5 years long. Which one would you like me to talk about first? Doctor, I think 3 years. I would like to know more about that. Which one is that? Actually, implant. And this is something that will be put into your skin. This will be long term for 3 years. You will be in contraception. The failure rate of this is this. Just watch out for the side effects, which are this. Okay, doctor, what about the 5 years one? It's this, intrauterine device. There is chances of this, this. Oh, okay, doctor. Doctor, actually, I don't want yearly protection. I'm looking for more, even if it's like a couple of months, I'm okay with. Okay, then we have 3 monthly. You know what I'm saying? So if this is made in a mind map in your brain, it's going to be so much easier to talk to that patient. Okay, then coming to the contraceptive rules. Now, sometimes the patient comes to you. There are two basic. There are two. What is it? There's three. Okay, don't look. Remember, guys, keep this in mind, and because this is a little confusing, so that's why I've made a whole map about it. Listen to me very carefully. The purpose of contraceptives isn't just one. You can also use it. Let's keep it simple, and let's just talk about the COCP right now, or the pills. They have 3 functions. They have one function we've already talked about. What was the function, guys?
Contraception.
Exactly. Preventing pregnancy. There's two more ways we can use contraceptive. Any idea?
Regulate the periods and stop the periods.
Very good. So regulating periods for someone with maybe PCOD, someone who's having irregular periods, you usually use contraceptives to regulate the periods. Okay. That's one function of it, and well done. Aisha has said the third one. we have a new function added to the pool. It's called stopping periods. For instance, someone wants to go on a vacation. We want to swim on our vacation. Can you please stop the periods? They come to you with this complaint, the girls, okay? So they're like, doctor, actually, I'm going on vacation. Could you give me something to stop my period? So this might be. So for that, you need to know that, yes, you can give contraceptives. COCP can be given to stop period. Just make sure you rule out what? What do you have to rule out before you give this?
Ovarian
Pregnancy.
carcinoma,
Pregnancy.
breast.
Pregnancy. And what else? What other things before you're about to give COCPs?
DVT
Cancers.
and migraine.
And DVT.
Very good. Most likely she won't have anything, okay? So how will you tell her to stop it? Okay, now listen very carefully. So this is how the COCP comes to you, like the COCP medicine. It is very interesting. I want you to watch this because nobody really teaches these things, because although these are basics, but I'll be very honest with you, they're not easy to retain unless you're like Aisha, you're a gynecologist. You're a genius gynecologist, not just a gynecologist. Well done. So why is this not? Okay. So great, of course. Sorry. Just give me a second. Okay. So usually the packet of contraceptive or COCP comes like this. Oh my God, what is wrong with the world? Great. So contraceptive packet, usually the strip of pills comes like this. Look very carefully. Nobody will ever teach you this, okay? Except for Aisha, if she gets time for you guys. Okay, so usually the pills come like this. They're like that. Okay, so there are about all, like for 28 days, all the 28 days you have to take pills. Okay, I'll tell you how. Okay, so these are the pills that come. Okay, however, remember one thing. The last row of pills are actually dummy pills, which means actually you are taking the pills for 21 days. When you are doing contraception, I'm talking about the purpose of COCP doing contraception. You take these pills, these are for 21 days. And this is the purpose of contraception. You take them for 21 days and then you have to stop taking them in order for you to have periods. Okay? If you don't stop taking them, then your periods stop. That's interesting. So, however, still people we put on contraception, we tell them to take this entire packet every month. It means they have to take the dummy pills as well, just because we don't want them to get out of the habit of taking daily pills. Okay, that's why we put dummy pills, meaning they have nothing, no contraceptive in them, just them have periods, and then they take out a new packet and they start again for 21 days. So 21 days are actual medication. Now coming to the purpose of, I want to stop my periods. So simple as that, you tell them to discard the dummy pills and just take 21 pills and then take another packet of the same contraceptive and start again on the 22nd day. Please tell me that makes sense. Okay, guys?
Yeah.
Okay, well done.
Yep.
So if a patient comes to you with the purpose of stopping periods, then you have to tell her, discard the dummy pills. That's all. So doctor, actually, I just want to like not, I want to say, oh, is there any specific reason? Doctor, I'm going for a vacation, blah, blah, blah. Okay, then you're just going to ask her any kind of symptoms. Do you notice any clotting in your leg, any blah, any migraines, any headaches? No, doctor. Everybody in the family is with it. These are the questions you'll ask. And then finally, thank you so much for talking to me. I will be able to prescribe you something to stop your periods. Okay. Basically, let me explain it to you a little bit. So first things first, I'm going to give you a combined oral contraceptive pill. Okay. So the pack, exactly how I explain it to you guys are going to explain it to her. So the pack comes in the form of pills. Okay. So there's going to be like 28 pills in it. Okay. What you are going to do is you're going to discard the last 7 pills, because these are actually dummy. You don't need to explain too much because she's not a doctor. Just tell her discard the last row of pills and start taking another packet of pills at the 22nd day. Just explain to her that, okay? However, most important part in this case, you have to tell her, I advise that you don't do this for more than 2 cycles. So we're saying that once you took, okay, you took a 22nd day, you changed to a new packet, you start taking another pills. And then 21 pills again, the 22nd day you start taking again, but we do not recommend you doing this for more than 2 cycles. Are you following me? Is there any specific reason why, doctor? Yes, it's because when you do it for more than 2 cycles, then you'll get a lot of symptoms. For instance, you'll get nauseous, you get severe pain, and it's not going to be good for you, basically. Obviously, because obviously you're in. Yeah, Aisha, go ahead.
Yeah, because when we have to tell the patient that they should bleed at least every 3 months, like then there is a endometrium will not shed off, and there will be risk of endometrial hyperplasia.
Amazing, amazing.
Similarly in the PCOS we do.
I'm
Like we
glad
tell
we
the
have a
patient
gynecologist. Yeah. Keep going. I'm so sorry.
Similarly, in the PCOS patient, we tell the patient that at least like in those patients they don't bleed mostly like they bleed very after 2 months, 3 months. So at least in a year they should bleed 4 times. Like they should bleed every 3 monthly. So if they are not bleeding themselves, we are going to induce the bleeding. So basically the reason is that endometrium will not shut off. It will keep growing, and it can lead to the risk of endometrial hyperplasia.
Guys, that's such a good concept. I'll be very honest. I actually didn't know before this that the risk of endometrial hyperplasia is the problem. Anyway, but never you need to tell the patient endometrial hyperplasia. But this is so good for our knowledge. I'm so glad we have a gynecologist on board today. So now you guys know the concept of it, so it's even better. So anyway, just make sure to tell her, but we don't recommend to do it more than 2 cycles. Just to explain to patient, just say, because you then have some symptoms like you'll have nausea, and because you're taking so many hormones, the symptoms might go. So that's why we don't recommend that. Just say simple as that. Okay, that's about it. So that's how contraception usually prevents. Okay, so now we're done with the contraception. Let's take a break, and the final part of gynecology will happen after the break, which is gynae, actually in gynae in person. And I'm going to ask you all about the basics of gynae, like what is a uterus, what's happening, what is endometrial, like all this will be discussed. Let's take a 15-minute break. Yeah, let's do that. 15-minute break, okay? Refresh your minds, because I don't like overwhelming anyone. I don't want anyone to be like, oh my God, too much information. I need to get some space. So take that 15-minute. You deserve 15 minutes. Okay, guys, see you. I'm back, guys. Let's do this.
Great.
Look at this activity. These active people. Well done. So the scene is that I've decided that just last 30 minutes and we'll finish the class, okay? Because we're all about to die because gynae is too much. And the only thing we'll have left is the final part, which is like the gynae part, right? Thank God, bro. Thank God. Okay, because I just realized that we can do sexual stuff tomorrow because sexual, as in the guy, like the vaginal infections, we can do them tomorrow. So I realized we can totally finish this quick. Okay, so first let's talk about basic concept. Let's talk about the basic concept. Okay, so we all know that these are the ovaries. This is the uterus. Everyone should know basics, honey. If you don't know the basics, how can you know anything in the world? Like, I'm so sorry. I'm so rude anyway. But like, if you don't know the basics, then you won't be able to understand stuff. Okay. So first things first, when it comes to infections and stuff, right? So just remember one thing, that those infections usually start from here and then they run up. When they run up and they reach the uterus, that's when you call it, what do you call it? Who is going to tell me? What is this called?
Pelvic inflammatory disease.
Well done, Aisha. Okay. So when the infection that was outside has entered the organs of pelvis, that's when you call it the pelvic inflammatory disease. That's what we're going to discuss today. And then the problem with pelvic inflammatory disease is that it is kind of a red flag in a case that we'll need to give them IV antibiotics now, because when it's reached your pelvis and if someone's, because the, what are the symptoms of pelvic inflammatory disease? Who is going to tell me? PID. Main symptoms,
Lower
main.
abdominal pain and discharge.
Very good. Lap and history. More better way of saying the discharge, I'll tell you in a while. But very important, fever and chills is a very, it's a red flag as well. And it's also a sign of PID. Most important, discharge is not simple discharge. It's history of many discharges in the past that he ignored. Okay, history of he will say, yeah, doctor, I usually discharge is like very normal, like it stays all the time. And you'll be, honey, it's not normal. Okay, so which means at first he had those lower infections, lower sexual infections that we'll talk about tomorrow. But he never got them treated. That's why these went inside his pelvis then. So that's a history of many discharge with fever, chills, and lower abdominal pain is what we call the pelvic. But because lower abdominal pain is going to be a characteristic of many gynecological issues. To differentiate it from others, PID carries the fever, chills, and the discharge history. Okay. Let's talk about how to deal with a girl that presents with PID. So all you do is take basic gynecological history. Doctor, I'm having lower abdominal pain. You explore the complaint, OD, para, Socrates, whatever it is. Okay. Guys, always remember the pain rule. When you enter and patient complains of pain, before you start after Rapo, before you talk about OD, para, Socrates, I advise you ask her, okay, Alice, are you comfortable enough to talk right now? Would you like me to give you something? She'll say, no, no, I'm okay to talk. Then you continue talking to her. Okay. However, if she says, no, doctor, it's so much pain. Oh, I can see you're quite worried, Alice. Okay, could you rate your pain for me from 1 to 10? Because according to the intensity, you are going to offer her painkiller. If the pain is more than 8, you offer her morphine and intense stuff. But if it's less than 8, you begin with a step ladder treatment. Did you take anything from home? No. Okay, then I'll give you Brufen, ibuprofen. Don't say Brufen is in like our country. It's ibuprofen, the formula name. Paracetamol. Okay. So this is the pain rule. I hope like in you were supposed to learn this in abdomen. Okay, the pain rule. So anyway, so could you tell me what's going on? Doctor, I have pain in my tummy. Okay, where site is important. Where is the pain? It's lower on the right side. Whenever, honey, listen to me, a female presenting with lower abdominal pain, blindly ask her last menstrual period. Okay, blindly, like don't even like ever think. Even if it's like 100% seems like appendicitis, you cannot miss LMP. You cannot miss it. You can now, if you don't rule out pregnancy, I'm not talking to you. Okay, it's not like you're going to be a safe doctor or not, but you should always do that. Okay, can you tell me, is the pain radiating anywhere? No. Okay. Is there anything associated with pain like discharge? Oh yes, doctor, I've been having this for a lot of days. Have you noticed fever? Yes, doctor, I'm also very low and I'm feeling sick. Okay, so this is pointing towards PID. So now you go for PMFTOSA, sexual history. This is in gynae. Always start your sexual history and gynae history. Two things you have to add on. In special questions, you're going to add on in history structure. What histories? Sexual history and what do you call it? Gynae history. How do you take gynae history? Don't ask too many questions. Just say LMP, how's your last menstrual period? It was whenever. And can you tell me if it's regular and is the bleeding heavy? No. Okay. And are you using any contraceptives? No. That's enough. That's enough for gynae history. Coming to sexual history, are you sexually active or not? That's the only question you need to ask. Tomorrow, I will teach you how to take proper sexual history in like a hack way. Okay, so I'll give you a structure for sexual history tomorrow. But in cases of gynae, keep sexual history short. Keep gynae history long. So who's going to tell me gynae history? What's the first thing? LMP. What's next? Keep it short always.
Regular, is it regular or it's irregular, and then amount,
good.
and are you using any contraceptives?
Brilliant. That's amazing. So these are your main pointers. Because don't try to extend this history too much. Even this much is fine. And only ask this in gynae cases, not in every case. You start asking so many questions. Case specific. If it's abdominal scenario, like tummy GIT scenario, you elaborate on soak rates. If it's, for instance, sexual scenario, you elaborate on sexual history. If it's sleep scenario, you elaborate on sleep history that I told you, 4 questions. But if it's gynae scenario, then you elaborate on gynae history, which means sexual history will be only 1 or maximum 2 questions. Which means sleep history, if she has sleep issues, you will ask only maximum 1 question or 2 questions. This you need to understand. Okay, this is called the relevancy rule. I just made that up right now. Relevancy rule is according to the case, prioritize the right question. If it's a gynecological question, yes, she has sleep issues. Yes, she does. It doesn't mean you ask too many questions about sleep issues because gynae questions are going to dominate this entire scenario. Okay. Now coming to PID, how do you treat it? Okay, I will have a look at you. It will involve me doing your vitals. Number 1, vitals. Number 2, I will have a look at you. I will do your tummy exam and check your temperature. Don't forget that. And then I will also do your vaginal examination. In bedside test, I will do UPT. So remember all of these important things when it comes to verbalizing examination. You'll do number 1, I like to do your observation, including temperature, heart rate, and your breathing rate. Apart from that, I will have examination. I'll have a look at you, which will involve me seeing your tummy and your vagina, your pervaginal examination, if that's okay with you. Or you can just say your front passage examination. Will that be okay with you? Yes, doctor. And I'd also like to order a bedside test in the form of a urine pregnancy test. Thank you so much. The patient will hand you over the clipboard. It will say she's not pregnant. Temperature 39 degrees C. Abdomen is tender, vagina, you see, observe a discharge, green discharge. So what you need to do, all right. So it seems like you have a condition called pelvic inflammatory disease. It just means that your organs inside your pelvis, which are your uterus, your ovary, these are all your womb. Don't say uterus, say womb. Replace the difficult words with easy words for patient. Your womb has an infection going on at the moment, which is why we will need to admit you for now. Is that okay with you? Whatever her name is. Why have we run out of names? Rebecca, is that okay with you? Yes, doctor. Okay. Would you like to know what we'll do when you're admitted? Please, doctor, let me know. Firstly, tests. We'll take some swabs, okay, from you, from your front passage, and we will, send them to the lab to find out which bug is responsible for this. We will do blood culture, which means we'll take some blood from you and we will culture to see which bug is the culprit. Are you following me up to now? Yes. I will also carry out an ultrasound. Now, who is going to tell me the complication of PID? Who's going to tell me the complication?
Ovarian abscess.
Yeah.
Ectopic
Well done.
pregnancy.
So pelvic abscess, basically abscess is what we're worried about. That's why we are doing an ultrasound to rule that out. Because someone's feverish, you have to rule out abscess. Okay, if it's an abscess, we all know we need to drain it. So make sure you say the ultrasound. We'll also have a look at your womb with the ultrasound, so we can be sure that everything's okay. No need to tell her to see if there's abscess. Don't scare her. Keep her in the safe. We like to check if everything's okay. You are safe. Okay. All right. And while you're admitted, most importantly, we'll give you antibiotic through your veins. Are you following me up to now? Yes. We will also just call to the gynecologist. She will also come and have a review of you. Is that okay with you? Yes, doctor. All right. I need to tell you, Joanna, that this is a curable condition. Okay, pelvic inflammatory. She might ask, doctor, is this curable? Am I going to be okay? Yes, Joanna, definitely this is curable. With the right antibiotics and right monitoring, hopefully you will be fine in a couple of days. Okay. However, I want you to keep in mind that there are some complications of this happening. Sorry, some complications that can happen as a result of this disease. Okay. Now, it's not necessary that everyone has these, but it's something that you should keep in mind. Don't ever forget to tell the complications. Okay. And sometimes what happens is this can lead to, what's the most important complication we need to counsel her about? Who's going to tell me?
Infertility.
Brilliant. Infertility is actually why we're so stressed out of telling her the complication. Might lead to infertility. Okay, there might be chance. So first, go for the easy ones. There might be abscess, or sometimes it can even lead to, Joanna, sometimes infertility. Okay, but once again, it's not everyone. I want you to keep this in mind. It's just the nature of this disease. Are you following me? Yes, doctor. Okay. Most importantly, don't forget this. This is something we'll talk about tomorrow. I will have to call partner notification program. This is basically when someone has had, because PID is sexually transmitted. The reason you have PID is not exactly sexually transmitted, but it's repeated sexually transmitted infections. Okay. So you need to screen their partner as well. So you have to, tomorrow I'll teach you more about the partner notification program. This is a new program. Like we had the HCPC, NUPAS, CRHTT, AR, what the heck was that? ARTT, something like that. Addiction Rehabilitation Treatment Center. Okay. So just like that, we have a new program we'll introduce tomorrow, PNP. So PID, since it's whenever there's sexual involved, you go for the PNP, which I'll talk about tomorrow. Okay. But for now, just remember in PID, the only treatment is IV antibiotics, admit her, swabs, blood culture, ultrasound. Tell her about the infertility. You have to tell her. Okay, there's no such thing as let's hide it from her. Maybe she won't have it, but you have to tell her. Otherwise, she can totally blame you that, I was admitted. I got infertile since I got admitted. She'll think admission was the issue. Okay. So coming to the next gynecological complaint. Okay. Who's going to tell me this? We're going to the next disease. Before we go to the disease, let's draw a uterus. This is our two friends. Then we have this caveman. And then we have the tube. Okay. I don't know why I said it so badly. Okay. If I tell you that this is the disease. Guess it. I dare you guys to guess this disease.
Yeah, endometriosis.
Endometriosis.
Well done. Give me the definition of endometriosis.
Pregnancy, tissue,
Mhm.
womb tissue outside the womb.
Well done.
Yeah.
Okay. Anywhere outside. So once again, this will also be a lower abdominal pain, but how do you differentiate this pain? How do you differentiate this from other gynecological issues?
It's a cyclical pain, like when there is going to be cycle.
Dysmenorrhea, meaning usually related to cycle pain. Dysmenorrhea before periods or during periods, she'll be dying. She'll be dying. No offense to her. Okay. She'll be like, there's just too much pain. Like she'll have to, she comes to the hospital every time just for a painkiller injection. That's how bad her pain is. And it always happens during or around her periods. Okay. So whenever there's a female with lower abdominal pain, do the LMP, do her gynecological history minor. So in the gynecological history, naturally you'll ask her LMP. No, nothing, right? Okay, fine. Can you tell me how's your regularity of the cycle? It's regular. And how about any heavy bleeding, any pain during bleeding? Okay. Oh yes, doctor, this pain always comes. Or maybe when you ask Socrates and when you ask the timing of the pain, any relation of the pain, then she'll herself tell you it's always when I'm doing the period situation, right? So I'm doing the period, so that makes no sense. Anyway, so point over here is pelvic pain worse during periods and sexual intercourse. So all gynae cases, you do some sexual history and a gynae history. Okay. So sexual history, you can totally ask her, okay, is the pain worse during, if she says it's worse during periods, and how about during, are you sexually active? First, always ask that question. Yes, I'm sexually active. And is your partner male or female? It's a male. Okay. And do you perform penetrative sex? Yes, doctor. And is it painful when you have sex? Yes, doctor. Definitely ovarian. Okay. So tummy pain female is equal to when was your LMP? Because you always have to rule out it's not ectopic pregnancy. That's a red flag basically. Always rule out ectopic pregnancy. Red flag of entire gynae. The entire gynae, you guys have to remember that entire gynae's red flag is just ectopic pregnancy. So always ask LMP. Okay. Ask LMP. You have to make sure she's not pregnant and having this pain. She's not pregnant and having it. It doesn't matter, because what if that discharge is actually blood and actually ectopic pregnancy and not PID? Okay. Now that we know how to diagnose endometriosis, we'll talk about Socrates. We'll tell her, because she's a female, we'll already, because it's not making sense in a GIT point of view. No, she does not have jaundice. She does not have vomiting, diarrhea, nothing. Okay, then any association, maybe fever. No, it's not even PID. Okay. Are you sexually active, Laura? Yes, doctor. Could you tell me when was your last menstrual period? Oh, it's recently. Would you say that this pain is related to maybe when you have your menses, anything like that? Oh, yes, doctor. She'll never reveal it to you. You have to get it out of her. When you're not understanding anything, when you'll be talking to her, that's when you'll resort to this, okay? Females always think gynae when it comes to tummy pain, okay? And always in examination, I'd like to carry out a UPT. Even if you know it's appendicitis, do a UPT. Even if you know it's a just lower abdominal pain, UPT. Lower abdominal pain, UPT, female, okay? Not in males. Don't do a UPT in male. Am I? Obviously, okay? Anyway, how do you manage endometriosis? This is a good question. And this is something that if you try to find the treatment of endometriosis, you won't really find it anywhere. Well, no, you obviously will find it, but it'll be very confusing. So let me explain it to you today. First things first, we're going to do ultrasound to see if this is actually the condition we're talking about. However, what is the confirmatory test of endometriosis? It's not an ultrasound.
Laparoscopy.
Laparoscopy.
Okay, laparoscopy is the test, but ultrasound is less invasive, so we go for it. So we are going to carry out an ultrasound, okay, just to see if, because this is my suspicion, we need to make sure, okay? Once your ultrasound is done, usually our confirmatory test is laparoscopy, but in your case, it's not severe. We don't need to go towards laparoscopy because that's more like invasive. That's like a surgery procedure, but don't worry about it. Are you following me? Yes, doctor. Now, could you tell me if you have any plans of getting pregnant? This is a very important question. Okay, let's just add this on. Plans of getting pregnant. This is our first question. No, doctor. Yes, doctor. This will tell us what treatment we're going to give in endometriosis by knowing if she wants to get pregnant or not. If she says, yes, doctor, I do. No. Yes, doctor, I want to. So first things first, you're going to do, I will give you pain relief. That's the most important part because there is a whole scenario of pain. I will give you pain relief in the form of NSAIDs. Okay. NSAIDs, don't say NSAIDs. I'll give you some pain relief. Okay. Some painkillers. Like I'll give you ibuprofen and that will help you deal with the pain. Are you following me? Yes, doctor. Okay. I am. And since you told me you are not trying to get pregnant, we will consider putting you on some hormonal therapy. So basically endometriosis is, Dr. Aisha would know better, is that we put them on hormonal treatment. We give them some medication, and that's something, if you don't know, you don't need to really say the name of the medicine as a junior doctor. You can just say I will have my senior come in and put you on medicine where they will give you the hormonal. So that will make your condition better. Okay. Might be progesterone that will give you. All right. Does that make sense? However, if she says, I want to conceive, then we'll cancel this. Rather, we'll say, I will refer you to the fertility clinic. If you are sitting in the GP, you can refer her to the gynae, refer her to gynecologist. Okay. If you are sitting in the gynecologist unit, say, I will call my senior and we will think of starting the hormonal therapy. It's not like it's unsafe for you to start, but it's better that the senior suggestion to start something, because hormonal treatment is something usually our seniors tell us what to do, like give her the progesterone or whatever it is. Okay. At any time we feel like, or if it seems like, your pain is not improving, you're not getting better with the treatment that we give you, we might need to resort to surgery to excise the endometriotic tissue. Does that make sense? So the treatment of endometriosis is basically, number one, pain relief. Number two, are you getting pregnant or not? No, hormonal. Are you getting pregnant or? Yes, it's fertility clinic referral. And third, do let her have an idea about the surgery. If required, if severe, we might need to excise tissue. But once again, my senior will be better, or the gynecologist will be better able to decide that. I hope that makes sense. Now coming to our third disease, which is ectopic pregnancy. Where are you, ectopic? Where is the ectopic pregnancy? So basically, a patient will present to you with a pain, lower abdominal pain, severe, and she will be in the ER this time. And in this case, you'll just ask her LMP and she'll tell you 8 weeks. And she's in pain. And when you ask her, do you have discharge? No. Are you taking any contraceptive? Yes, I have a device kept inside my uterus. Biggest risk factor of ectopic pregnancy. In ectopic pregnancy, always ask, what do you ask? Do you have any contraceptives? Ask her the contraceptive. Okay. So anyway, the reason I haven't added ectopic pregnancy over here, it's very easy. Admit. Call in the guy. You are not to deal with ectopic pregnancy on your own. That's not for you as a junior doctor. That's for, I will call in the gynecologist. You just have to counsel her what is ectopic pregnancy, why she got it. And the gynecologist will come. We need to admit you. That's the only treatment for ectopic pregnancy. You can't say things out of yourself. Maybe she might ask you, what are they going to do for me? So they're going to monitor you. They're going to see there are different therapies available. One of them is some medical therapy called methotrexate, or they might do some surgery, but that is up to the gynecologist. Okay. Now let's go to the final disease, which comes PCOS. Patient has presented to you with mood swings or whatever it is. And when you ask her, like, could you walk me through your last menstrual period? Doctor, it's been 3 months since I have. So you can see irregularity. Okay. So it was 3 months ago. All right. And when you have periods, are they heavy? Doctor, they are so heavy. What's the point of that? The point here is irregular heavy periods. Anything that's like periods are like messed up. Either they're a lot or they're like spacing out. They're just irregular. They're just not like consistent. So basically all that means is some hormonal imbalance in the body is going on, which we call as polycystic ovarian syndrome. Then you proceed to ask her, have you noticed any maybe weight gain, weight loss, any changes in the weight? Yes, doctor, I've gained a lot of weight. Okay. Any other cosmetic problem, maybe any hair or any acne you noticed on the face? Doctor, I've noticed that I have manly hair coming out. Okay. And apart from that, who is going to tell me? Genius? Aisha cannot, because Aisha is a genius. We all know I want you guys to tell me, what is the red flag you'll ask in PCOS? Let's see your Plab 1 knowledge. You're going to nail it if you answer this. What red flag will you ask in PCOS? Okay. Seher.
No, I don't know.
Why'd you unmute your mic? Because you want to show you would have
No.
participated. You're an active student. Is that right?
Yeah. I just don't like get it.
Yeah, Shaista.
Yeah, shall we ask her about thyroid symptoms and diabetes?
Okay. That's very good, Shaista. You're going in the right direction.
You know, the thing is that it's PCOS, right? So if it's a PCOS, then infertility, I guess so.
Diabetes as a complication.
Yeah, okay. So basically, let me tell you guys. Okay, Aisha, would you like to try?
I don't know what do you mean by red flag, like
Oh,
in
okay.
this.
So basically, red flag means that to make sure that she's not dying from this. How do I explain it? Guys, actually, let it go. Let me answer this question because maybe it's not the easiest question I asked. Because PCOS is a little bit hormonal imbalance, your brain should be thinking a little bit about prolactinoma. Okay, so that's a pituitary tumor and it causes vision problems. So ask her, have you noticed any vision problems? Have you noticed maybe any mm, weight loss? No, doctor. Okay, so that's it. So basically, thyroid symptoms very good, but a red flag, all red flag basically what it means is that to rule out something that can kill her. That's what red flag means, Aisha. So when someone comes with PCOS, similar hormonal imbalances occur in prolactinoma as well. So we have to make sure it's not prolactinoma. Like we have to make, although it looks nothing, it looks 100% like PCOS, but we have to ask the red flag questions. This is for us to pass and be a safe doctor. So that's why we have to ask that. Okay, so prolactinoma is the red flag. All right, so what we're going to do, what is the treatment for this? The treatment is that I would like to do your tests. Usually PCOS presents in the form of results. They already gave you the result, LH FSH ratio 3:1. This is a diagnosis of PCOS. When the LH is more than the FSH, where FSH is normal and LHS is raised, these are the ladies that are actually having PCOD. Big sign of PCOD, LHS FSH ratio is raised. Don't forget this. If this is the only test she provided, you'll say, okay, I'll run some more tests on you, which will involve me doing your thyroid profile, your prolactin level, your testosterone, and your sugar test, because we all know that's the complication. Okay, we'll also, if you want cholesterol, okay, and apart from that, we'll do an ultrasound because the diagnosis of PCOS is ultrasound. And once you see in the ultrasound cysts in your ovary, you'll see cysts on ovary plus clinical symptoms is equal to PCOS. Yes, she has PCOD. Okay. So the criteria to diagnose PCOS is ultrasound should show those ovaries, plus there should be clinical symptoms. And I think LHFSH ratio should be raised, something like that. But that's not the point. You all know. So whenever PCOS presents to you, what is your priority testing? Who's going to tell me? Tell me all the tests for PCOS.
LH ratio, FSH,
Very good.
and testosterone, dihydrotestosterone,
Very
and
good.
blood sugar levels,
Very good.
and prolactin levels.
Brilliant.
And the most important is the TVS, transvaginal ultrasound, to look the ovaries.
Very good. Got it, guys? So ultrasound, well done. So these are, don't ever forget these tests of PCOS, okay? So whenever PCOS girl comes to you, you'll tell her these are the tests I need to do for you, okay? What is the treatment of PCOS? There is only one treatment. I've written many treatments, but there's actually just only one treatment.
Weight loss.
Lifestyle, yeah.
Well done. Weight loss. So your purpose is going to be to explain to her that, honey, listen, we need to talk. Okay, we need to talk. This is going to be kind of awkward. Okay, I want the most important, you have PCOS, explain it to her. It's when your ovaries, which are basically organs of your pelvis, these basically undergo some changes. Therefore, you have hormonal imbalance. So this usually can be corrected by, most importantly, weight loss. If you work to lose that weight, many things can be fixed. So weight loss is something, Alice, I want you to know, is actually the mainstay of this treatment. Okay, are you following me? So if you're able to do that, that's the best way to fix this problem. Okay, I will refer you to a dietitian so she can make you a better diet and you can slowly do well and maybe work on it. Are you following me up to now? Yes, doctor. Other treatments, if her periods are the problem, give her cyclic cyclic progesterone. Okay. So we will put you on hormone therapy in which will give you progesterone. But however, if you're sitting in gynecologist, my senior will come and be better able to prescribe you that. Or if you're sitting in GP, I will refer you to gynecologist. They will prescribe you the best, hormonal treatment for this. Okay, so your periods become regular because periods are the main issue, right? Apart from that, you are telling me your hair is a problem. Acne depends on what her problem is. If it's the hair is the problem, then you have to tell her weight loss is the first thing. And obviously retinoids, you can prescribe your retinoids. You can refer to dermatologist for acne, shave the hair. There's literally just supportive management. The actual treatment lies within the weight loss. The actual magic begins when you lose the weight. So this is something you need to explain to her. And apart from that, we will keep monitoring you. Tell her about the side effects of PCOD. I want you to know that this condition does come with some complications. I want you to, first thing is the blood sugar. So we'll keep monitoring you with a figure called the HbA1c. We'll keep monitoring you for that. Okay. But, and sometimes I'm sorry, but like, I'm sorry to tell you, but this might lead to infertility as well. Okay. However, it's not something that's going to happen to you 100%. Once again, I told you, if you can lose your weight, all of these things can be solved. But depends on you, your determination. Okay. And then advise her lifestyle modification. And I advise you cut down on junk, do more exercise, and eat healthier. I'm not saying start eating healthy right now. I'm saying maybe in this week you add on 1 fruit. Next week, add on 2 fruits. This is something I'll teach you in counseling, how to counsel her. So you can see mostly Plab 2 cases are linked to one another. Gynae is linked a lot to the sexual health. So anyway, so this is, if she doesn't want to get pregnant, then it's okay. That's good. That's good. You just need to give her the cyclic progesterone. And I will also have my senior to review this medicine just in case. Okay. And apart from that, see, Alice, what I need, you need to basically counsel her. When we say counseling, we mean trying to convince the patient, or, like walking the patient through it. Like, this is our advice. You should do this. I'm not saying cut it down. Like kind of convincing the patient, or selling yourself to, not yourself, to the patient, selling life to patient. Okay. So these are the major gynae diseases that will come to you. Okay. Now I'm going to do a rapid fire because that's how we go, because my classes are all about making you guys develop these reflexes. Okay. So this is going to be intense. Guys, always remember, see, gynae is overwhelming. And once whoever was here since hour 1 to hour right now, it's not going to be overwhelming for them now. I'm telling you, this is literally all that comes. And remember, when something is too much, my biggest advice to you is organize. What I mean by organize, write it in bullet points, only the important things. The rest of the sentence, say it in your own words, in 1 line, not more than 1 line. And these are things you can only understand if you were here since day 1 of my classes. What I mean by 1 line, like don't speak more than 1 breath, because you want to make it conversation rather than speech. Okay, so understand this, that if any disease comes that I haven't taught you in today's class, it's okay. My purpose over here was to make sure to go through the gist of gynae, main diseases of the gynae, that if you try to do yourself would be really difficult. Any extra disease comes, it's probably going to be extremely easy. And what's most important, I've made you guys, I've trained you guys on how to make it easier for yourself. 3 or 4 points, 2 to 3 points of treatment, not more. Bullet points. Okay. So if I say patient has presented to you with, guys, you have a 20-year-old Alexa. She has presented with lower abdominal pain. Take history.
Any fever or discharge?
Fever is negative. Discharge is positive. Yes, yes, doctor, I noticed some discharge.
It's PID.
Yeah.
But fever is negative.
LMP.
Okay, good. That's a very good question. LMP, lower abdominal pain. She also has discharge. Should we ask her a little bit more about what she means by discharge? Because sometimes discharge is normal in some, not some discharge, some amount is also normal. She might say yes to that discharge, right? So you just ask her, what color is your discharge? It's white. That's safe, okay? How long has this discharge been going on? Nothing, doctor. It's just most likely she won't say anything like that. I'm just making it confusing for you. Okay. LMP asked. LMP is about 2 weeks ago. I had my periods. Lower abdominal pain. Fever is negative. Discharge, let's put it negative. I don't know why I was confusing you guys, but I wanted to.
It seems
LMP,
like ectopic.
last menstrual period was 2 weeks ago.
Yeah, and use of
Is it
contraceptive.
mandatory? Is it
No
mandatory for
use.
ectopic? Is it mandatory for ectopic pregnancy to be more than like 8 weeks?
No,
Is it?
ectopic pregnancy, LMP has to be, see, this is normal. We have 28-day cycle. So if 14 days ago she had her periods, we can't really say that with her history.
Yeah.
Get it? If she said 4 weeks ago, like a month, 5 weeks ago, that's
Yeah.
more than a month. So that's like she hasn't
Yeah.
had it. That's a pregnant. Okay. So
Yeah.
Is this
no use.
appendicitis? Is there any
Any
non?
specific timing of pain?
Oh yes, doctor, it is associated when usually have menses first day. It hurts like crap.
Endometriosis.
Or
Well done.
any yeah, I don't know.
Very good. So doctor, like I don't want to get pregnant. So like, what are you gonna do for me? Give me number one thing you're gonna do for her.
For endometriosis, if you don't want to get pregnant, right, then I'll
Hormone
involve my
therapies.
period.
Hormone therapies.
First
Like
give
I will
painkillers
involve my
and then
Pills and
hormone.
pain
hormonal
NSAIDs
therapy
and
after sitting on
hormonal
one month.
therapies.
Good. But my question is, what's the first thing you will say to her?
Pain
pain
relief.
relief,
Painkiller NSAIDs.
like
Well,
So once again,
ibuprofen.
guys, remember, when I say management, it doesn't mean treatment.
USG. Ultrasound
Sorry, what?
will be first.
Ultrasound. First, tell her I need to confirm. What if randomly I start you on treatment? Let me see. Okay, first we're gonna do an ultrasound to see or like confirm my suspicion. Okay. What is the gold standard diagnostic test for endometriosis?
Laparoscopy.
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 Okay. Just have that in mind. Now, coming to a 20-year-old, Alexa has come with lower abdominal pain. Take her history again.
When does the pain happen?
Pain is usually, doctor, it's happening just 2 days ago. It's just too much. Like it never happened before to me.
Is there
Does
any
it
gynae
increase during your
discharge?
period or during sexual intercourse?
No. See, guys, listen to me very
Not
When
carefully.
was your
You're not,
last menstrual period?
so you're not, listen, in Plab 2, please take this like Plab 2. You do not know that this is a gynecological scenario. In Plab 2, you don't know. Today we know we're talking about gynae, so we're thinking Plab 2, right? So when you enter the room, it shouldn't, obviously, gynae is not the first thing that's going to pop in your mind. Anyway, it happened 2 days ago. Does anybody want to do my complaint inquiry?
Can you exactly tell me where is the pain is?
Oh
Just
yeah,
point
it's
out.
right side lower part of my tummy.
Okay, and how does the pain started? Was it sudden or gradual? Sudden?
Yeah.
Can you describe the pain for me? Like, is it sharp, dull, or?
It's very sharp.
All right, and is it radiating anywhere?
It's radiating to it. It started in my belly button.
All right, and is it associated with any symptoms like nausea, vomiting, fever?
I have nausea. I can't eat anything.
All right, and did you have tried for anything? Did you try anything for it, like any medication?
No, not yet.
Anything make it better or worse?
Nothing.
Okay, could you please rate your pain on the score of 1 to 10, 1 being the lowest, 10 being the highest?
7.
All right.
Move on from the complaint inquiry.
Okay. So would you tell me that when was your last menstrual period?
Oh, it was just 1 week ago.
All right. And is there any discharge along with that? Do you have any discharge?
No.
All right. And do you have any other complaints like bowel complaints or urinary complaints?
No.
Okay. I think it's appendicitis or
Well
like.
done. Well done. That's what I was
Mhm.
trying to check. Like, don't always, like, obviously, because you guys are on gynae, you're gonna, but if it's making sense for medical, why should we go for? So in Plab 2, you will never know whether it's GIT, gynae. That's the topics we tell you guys, and you guys see examination to well done. So even J Raj got to it well done. Okay, because it doesn't make sense with gynae. So always, this is the look at Aisha, the way she took history, take for all abdominal cases. Like, don't be biased towards only gynae for like females and on like or only GIT and forgetting the gynae. So in females, keep both things in mind. That's all I'm trying to trade you. Okay. Patient has presented to you with. Patient is asking for contraception. Okay. Who's going to counsel me for how? Who's going to help me decide contraception? Tell me the questions you'll ask me. Hi doctor. Actually, I want to know like about contraception. Actually, I really want to start taking contraceptives.
Okay, we can help you with that, but is it okay if I ask you a few questions first?
Let me make it easy for you. Keep it contraception related questions, okay?
Okay, could you tell me why in the first place you want contraception?
Doctor, I don't want to get pregnant.
Okay. And have you tried contraception before this?
No. Today, like I recently had like a boyfriend and it's my first relationship, so like I want to know about it.
Okay. Just a few questions about your menstrual cycle. Could you tell me when was your last menstrual period?
A week ago.
Okay. And would you say that your periods are regular or irregular? Like
More than
after
regular. They're
21 days?
amazing. I love my periods. Yeah, they're always on time.
Okay. And would you say that when you do get your period, you bleed very heavily?
No. It's completely good, normal.
Okay. And just a few questions about your general health. Have you ever been diagnosed with migraine or have had recurrent headaches in the past?
I have severe migraine issue going on, doctor.
Okay, I'm really sorry to hear that. Are you on any medication for that?
Yeah, I'm taking like some random medicines that I don't know the name of.
Okay, and do you have any problems with your any problems like any problems with your blood clotting, any blood clotting issues at all? Any leg pain?
No.
Okay.
Ask this question like, do you have any long-term medical condition for like, for
Mhm.
example, any clotting disorders? Perhaps no.
Okay, okay. And then I think this is it. And then in the examination bit, I'd like to check her BMI for
Okay,
obesity.
forget the structure right now. Just help me decide a contraception. Ask me the required questions for it.
Yeah, so right now I would rule out migraine, DVT, and check if she's obese or not. And if any of these are positive, then we'll just prescribe her POPs.
Okay, so what is everyone's opinion on her giving me?
We should
Oh, and we also
also
have
ask
to
that
ask her preferred mode.
Which
for-
type of
Yeah,
and
what
contraception
does
she
she want
wants?
contraception
long-term
would
or
like.
short-term contraception?
Yes.
I love the like the activity. Like, you're like what? So guys, honey, like she's taking contraception for the first time. She doesn't even know what options she has. You can't just give her a random contraception without even telling her. You know what I'm saying? That's what I was trying to get to.
Mhm.
So ask her okay, one of you, Abira, go ahead. Ask me the questions and decide a contraception for me.
Okay, tell me that which do you have any idea about contraception? Like what are the types and anything like
Actually, I
that? So
don't.
far,
Oh, I want you to
okay,
tell me.
I will help you out. First of all, tell me that do you prefer any mode? Like there are different types of contraception. You can take it orally. We can have injections and patches. So do you have any
Oh,
idea which?
doctor, I'm terrified of anything coming into my body. So I don't want any injection, anything like,
Okay,
attacking me.
that's understandable. Okay, no worries. So, just wanted to ask you that do you want long-term contraception or for like
Beautiful question. Very good question. Would you prefer a long-term contraception or a short-term? This is going to rule out so many things. Doctor, I'm looking for something short-term. I really don't mind.
Okay, that's fine. So, for the long-term contraception, we have different options like pills. There are, as you told me, like in this case, does she has any of the side effect, like any of the contraindication?
See, migraine in front of you.
Right. Okay, so in this case, you told me that you have migraine. So, what we are going to advise you, we will advise you a different form of contraception, that is progesterone only pills. That you are going to take the tablet
No,
in tablet form.
but doctor,
Are
what
you
about patches? I also heard about patches. Why don't you educate me on patches?
okay? Yeah, just okay. There is another option you can go for. These are the patches that you use weekly, like on weekly purpose. So
Oh,
how
okay.
does
So
it sound?
basically, guys, lay down the option for her. So are you looking for something short term or long term? Doctor, I'm looking for short term. Okay. And do you have any like specification on how you want to take it? Are you okay with injections? Are you okay with, maybe some implant or maybe some orally? Yeah, doctor, please, I'm scared of injection, anything coming into my body. Okay. Now we've ruled out. When we've ruled out, we have two things in mind, the daily and weekly. Okay. So there are two types of contraception I'm going to tell you. Okay. Today. One is related to you taking it by mouth. This is type of contraception that you take on a daily basis. Okay, these are the pills. And then you have weekly contraception. These are patches. Okay, you take them on weekly basis. You just put the patch for a week. Okay, so these two are the options available. Doctor, can you tell me the failure, like how much failure? This is three, they're all equal failure rate, 3 in 1,000, which means every 1,000, 3 get pregnant. Oh, okay, doctor. So I think I'd go for the pills. I don't mind taking pills daily. I have a good memory. That's great. That's brilliant. Okay. Just keep in mind the side effect as well. Okay. You might notice some bleeding between your menstrual cycle, but I want you to know that's the side effect of it. Okay. So I have to tell you something important. We usually have two types of contraception: combined oral contraception, the progesterone only pill. However, since you have migraine, we are it is contraindicated for you to take the combined oral contraceptive. So we are going to start you on the progesterone only pill. Is that okay with you? Yes, doctor. Okay, at any time you want to know more about it, we can keep another meeting. I can discuss even more in depth of other options available. But for now, I hope you're okay with this. Yes, doctor. Thank you so much. All right. At any time you have bleeding that is heavier than normal during your menstrual cycle, then come to the hospital immediately. Okay, so you're basically giving a safety net of the side effects. Okay, who's going to help me decide now? Once again, guys, practice it. Who's going to help me? I want a contraception. Hi, guys, I want a contraception.
Okay, I'll do it now.
Okay, go ahead.
Okay, so I'll do it from the start. Okay.
Yeah. No,
Okay,
don't do
so
like a proper case, just
like
do
not from
contraception.
the yeah.
Okay, okay.
So you just okay. So how may I address you?
Alice?
Okay. All right, Alice. Alice, so can you please, tell me that for what purpose do you want to get contraception? Do you want to get it for like your controlling your periods to reduce cramps or just, to prevent the pregnancy?
Wait,
Hello?
wait, wait. Listen to me very carefully, guys.
Yeah, yeah.
When a patient comes to you says, I want contraception, she basically means I want prevention of pregnancy. Okay?
Ah,
The
okay,
word
okay,
contraception is prevention of pregnancy. So I was just
okay,
figuring out how to explain that, found the perfect words for it. Okay. If she's saying I want
okay.
contraception, you don't need to tell her. So otherwise she will just come, she'll be actually, doctor, can you just like I want to like stop my period. She'll be very like, what do you call it? Whatever.
Yeah, yeah,
Okay?
yeah. I get it. Yeah.
Care about it basically.
Okay.
Okay, and
Okay.
regulating
Okay.
menses, that's something you as a doctor will decide. She'll never ask you, I want to regulate my menses, give me, okay? So contraception is always pregnancy. I want to prevent pregnancy.
Okay. I get it. Okay. Okay. So, okay. Can you please tell me that do you have any medical conditions like migraines, blood clots, or high blood pressure?
No.
All right. By any chance, do you smoke or take any regular medications?
No.
All right, Alice. So are you aware of, other methods of contraceptions like pill, coil, injections, patches, or implants?
I don't know anything. That's why I'm here.
Well, all right, no worries. I'm here to, help you out with that. So, would you prefer long-term or short-term contraception?
Actually, I don't mind if it's, I just don't want short term. Like
You
I,
just
I
don't
cannot
want
remember to
to.
take medicine every day, and I don't like taking medicine through mouth. It's just something I can't. So I
All
want
right.
something
So,
that's like, yeah.
okay. So so we have like different, things for it. So there's a 3 monthly, there's a 3 yearly, and 5 yearly. Okay. So which one do
Yeah.
you prefer?
Tell me about the 5 yearly. That sounds like a longer time.
Okay, so in 5 yearly, we have like two contraceptive methods. One is Mirena, and the other one is an intrauterine device that we actually put in the womb.
Oh, no, no,
And
no, no. Doctor, please, no. I don't want anything going inside of me. No. I want
all
something
right,
else.
then okay, then we have 3 yearly, and there's an that's an implant that actually it does not go inside the womb, but in your arm. Like the 3 yearly, there's an implant. The implants were in the uterus or were in the
It's inside
were
over
in
here in the skin.
okay. Okay. So that can be
It's
like
inside your
go
skin.
into your skin. So that is, a 3 yearly one. And then there is a 3 monthly one that is a intramuscular injection that you need to get injection every 3 monthly. So it's on you, whatever
Okay,
you
so,
want to.
doctor, what is like tell me about the failure. How often do these fail? Like both of them. I want to know about them.
Yes, sure. So basically, the 3 monthly, it's like 2 in 1,000, which means that from like 1,000 females taking this contraception, two can still get pregnant.
Okay.
And similarly, like the 3 yearly, it's 1 in 2,000. That in 2,000 females taking this contraception, one can still get pregnant. And the 5 yearly one, as you said that you don't want it, but still I'm going to
Don't
tell
tell if she
tell
doesn't
you.
want it.
Okay. Okay.
Don't doesn't want it. That's
Okay. So
like
we
not
have
good
like a
for
3 months
kids.
and 3 years. Okay.
Okay, doctor, I think I want to go for the 3 yearly one. That's how you make a decision. You get what I'm saying? That was good. Well done, Seher. So this
Okay.
is
All right.
something that I want to brainstorm. This is how you need to make her make a decision that what are you wanting? Okay, and the only thing you need to like not give her is when she has contraindication to COCP, then you don't give COCP. That's the only in Plab 1, contraception was extensive. It was like if she's this years old, then and she has this problem, don't give her oh, that was so difficult. In Plab 2, it's not that difficult. This is easy. Okay.
Mm.
You just need to educate her.
Okay.
The only thing you'll have to contraindicate is, sorry, not give is COCP. Nothing else will be too difficult. Okay, guys?
Yeah.
So, what is this? So tomorrow I'm going to be teaching you more about STI, sexually condition. And you guys, I'm so happy to tell you, but I think, yeah, we're done with gynae, obs gynae. So we're done with women's health. Well done. Now try to do those 30 cases on your own. It's going to be piece of cake, piece of strawberry, piece of everything you love, your favorite burger or
I
whatever.
I said something else.
What did you say? I want to know.
No, 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 no. I'm not.
Please tell me.
No, I don't.
No?
It's just
Secret?
in my head. Yeah, yeah, yeah.
Okay, I can't even guess. So thank you all for joining. Today we ended the class early because you guys deserve an early ending because you guys were so active today. Brilliant performance by all of you today. I think I have a top student, and that is, it's very obvious. It's Dr. Seher. Well done, Dr. Seher. Brilliant participation since the beginning. She's active. After the break, I could hear her. I could hear nobody but her. And she was just like on it. And she's giving all the right answers. Well done, Seher. Okay. And it's not just a day thing. It's like I'll see from day 1 to day 10 who's going to do the best. Then I'll tell you guys about the 2 top students of my entire course. That's so much fun. Okay. Thank you so much for attending, everyone. I love you all. I love you all. Okay. That's a little intense, but this is how we need to be in Plab 2. Okay. We need to be exaggerative with our words. I love you, even if you don't give a crap about the patient. Okay. Enjoy your Monday because I know Mondays suck. That's why I kept it short so that Mondays aren't that hated. Okay. They're already like, nobody likes them. Okay. Thank you all for attending. Thank you, Doctor. Welcome, Arshi. Don't miss tomorrow's lecture and be on time, because like sexually, what was it? Sexual health? Oh my God. The sexual questions, it's a confusing topic. I know that people think that they know a lot, but it's very confusing, and even they know that they don't know. Oh my God, I'll explain everything. It's like all the doubts will be solved. Thank you so much for attending. Bye, guys.